Good evening, students. So welcome to the discussion of the grand test that occurred yesterday. So we had the new pattern of questions with the various video questions, image-based questions, and the new pattern of 180 questions that was given. And most of you have attempted it. So let's discuss some of the answers, especially from the medicine section and the allied sessions. So the first question that was there was a patient has suspected infective endocarditis, but blood culture is negative. Which of the followings is likely to cause, is not a likely cause? So the question here is not a likely cause for culture negative endocarditis. So we know Coxiella, Bartonella, and Triforema are three causes which produce culture negative. We do PCR for that. The answer for this is mycoplasma. So mycoplasma is not associated with infective endocarditis or culture negative infective endocarditis. Here you have a patient with cirrhosis who has come with confusion, and you can classically see the finger movement. So you see this is the asterixis or the flapping tremor. So we know the ammonia level is high. Now, why does this happen? So the option that they given for you was failure for the hepatocyte to conjugate bilirubin. That's definitely no. Accumulation of gut-derived neurotoxins due to photosystemic shunting. So photosystemic shunting. So this ammonia and etc., mercaptans, etc., will enter the systemic circulation. That's the correct answer. That's B. Deficiency of urea cycle enzymes. That's not a reason for hyperammonemia here. Cerebral edema can be seen, but the most specific answer here is B. So asterixis can be seen with other conditions like carbon dioxide narcosis. It can be seen with uremia and heart failure also. The next question, a 38-year-old, sarcoidosis is there, and they are undergoing imaging, and PET scan shows hypermetabolic activity in the mediastinal lymph nodes. So please remember, sarcoidosis, mediastinal lymph nodes is specific. So what is the best option among them? The most accurate option they have asked for here. So you can see that the PET scan is specific for sarcoids and excludes malignancy. Hypermetabolic activity may represent granulomatous diseases or malignancy. PET is not useful, and MRI is superior to SPECT. So please remember, PET is a very specific thing where it shows the activity. So hypermetabolic activity can be seen both in granulomas, infections, or malignancy. So the best option here is B. So B is the correct answer for this question that you see here. Now here, a patient who is resistant hypertension, so that means many drugs are there, comes with shortness of breath. And you can see this X-ray. It's showing the classical bat wing appearance. It's showing classical bat wing appearance, perihilar shadows. So this patient has a cardiogenic pulmonary edema. So that's what you can make out here. So cardiogenic pulmonary edema. So what's the drug of choice for that? So oxygen has to be started, and this patient's blood pressure has to be controlled. So the best drugs to deal is D. So the best drug to be chosen among this site is the nitrates. So nitrates is the best drug for lowering the blood pressure as well as decreasing. You can use diuretics as well as you can use patients with non-invasive ventilation. BiPAP can be given. So this is cardiogenic pulmonary edema. But please remember, the main feature about cardiogenic pulmonary edema should be cardiomegaly with the classical bat wing appearance. Though the cardiomegaly is not so classical here, but you can, in the history-wise, they have said medically resistant hypertension. If there was no cardiomegaly, then your diagnosis would have been ARDS and the treatment would be ventilation. So history is suggestive of cardiogenic pulmonary edema. That's why nitrates is a drug of choice. 66-year-old, exertional dyspnea, pedal edema, and abdominal distension. That means this patient has heart failure. And there is hepatomegaly, periorbital purpura, macroglossia. Very, very characteristic feature of amyloidosis. Please remember, amyloidosis produces a raccoon's eye, organomegaly, macroglossia, and there is deposition on various parts of the heart. So we have biatrial enlargement, restrictive cardiomyopathy. All these things cause restrictive cardiomyopathy, but this hepatomegaly, periorbital purpura, macroglossia is quite specific for amyloidosis. You will treat the patient with specific drugs which are used for that. Also, very importantly, we will have to confirm the diagnosis ideally an endomyocardial biopsy. But since there is macroglossia and systemic features, can take a biopsy from the subcutaneous fat pad, you can take a rectal biopsy or a nerve biopsy or the liver biopsy, and you have to see whether it's an ATTR or an AL type of amyloidosis. Based on that, we can have drugs which are useful for that. 32-year-old chronic diarrhea, weight loss, iron deficiency, anemia. You have steatorrhea also. There is low hemoglobin, low vitamin D. So, this patient has a disease which is affecting the small intestine. There is malabsorption of various things. So, vitamin D, anemia, hemoglobin, fat malabsorption, etc. happening. And this is classically showing the jejunum, etc. are pulled up here. And this patient is likely to develop what are the diseases? So, Crohn's is unlikely. Celiac is less likely because it is gluten sensitive. Intestinal tuberculosis goes to ileum and large intestine here. Now, the most specific is the tropical screw, and this barium examination is very diagnostic of tropical screw. In SLE, patient with nephritis, which combination best relates the activity of lupus nephritis? Please remember, activity is C1, complement. So C1q is very important. Antiphospholipid is for Apla syndrome, ROLA is for Sjogren's, histone is for drug-induced lupus, RNP is for mixed connective tissue disorder. So C1q with anti-dsDNA is the most specific. The patient comes with following results. So you have chloride of 113, potassium is 2.8, bicarbonate is 12, sodium is 134 here, pH is low, creatinine is normal, urinary pH is high. So remember, so here you have acidosis. If you calculate the anion gap, so 113 plus 12, so 113 plus 12 goes to 125, and 134 plus 2.8, your 1.2 to 136. So 136 minus 125, you're getting 11. So it's a normal anion gap metabolic acidosis with severe hypokalemia, and the urinary pH is measured is higher. So it should be normally less than 5.5. It's very high. So this is very characteristic of type 1 renal tubular acidosis. It's not a high manner. It's type 1 renal tubular acidosis, and the most commonly associated with Sjogren's syndrome and other connective tissue disorder. Elderly diabetic nephropathy comes with palpitations, tall T waves, hyperkalemia is seen. So what is the emergency drug? So always remember, calcium gluconate is given, then insulin is given with dextrose, then you give beta agonist, salbutamol nebulization, and then you can dialyze this patient. Now, what among this can work similarly? So please remember, beta agonist. You want to shift the cell inside, and the closest would be an epinephrine that would be used. The others would not be helpful. So the answer for this is D. 60-year-old tearing chest pain, and the BP is very high, asymmetric arm BP is new diastolic murmur. So this is an aortic dissection that's happening. The best investigation for aortic dissection is a CT angiography of the chest. It's an emergency investigation that you have to do, and you have to control the BP with the esmolol or any other conditions, and then this patient would require procedure. So CT angio is the drug of investigation of choice. 30-year-old hepatitis B, full vaccination done, having documented anti-HIV-based antibody. Sequence shows glycine to arginine substitution at 144 of the HBsAg determinant. What is the explanation for that? You'll see there. So what is this? So here there is an escape mutant. This classical glycine to arginine is the occurrence of an escape mutant that you're seeing. It is not a reinfection. Here there's a mutation that's called, and that is the HBV escape mutant. 60-year-old watery diarrhea, crampy abdominal pain, was treated with clindamycin. Now when you see there is abdominal tendon, distension, etc., leukocytosis is seen. Routine stool culture shows no organism. And you do an endoscopy, you can see very, very characteristically pseudomembrane, so much of slumpy pseudomembrane. And the diagnosis here is pseudomembranous colitis. Very, very characteristic feature. C. difficile. You will stop the antibiotics. You may have to start them on rifaximin, oral vancomycin, fidomaxin could be needed, and sometimes fecal microbial transmission might be needed. So this is pseudomembranous colitis diagnostic. Multi-drug resistant tuberculosis is being evaluated to start on treatment. Before you start on bedaquiline regimen, what should you be confirmed? So bedaquiline is the main regimen that is there. Very, very important. Bedaquiline that you're doing is the BPAL regimen where you're using levofloxacin. Quinolones have been used. So here you will want to see resistance to rifampicin and susceptibility to fluoroquinolone. Only then can we start on bedaquiline regimen. 65-year-old, 10 years history of chronic obstructive airway disease. He has mild dyspnea on exertion. You're seeing pH is mildly low, PCO2 is high, and 32 milliequivalents bicarb. So here, this is a chronic respiratory acidosis, and see the pH is almost coming to normalize with the compensation. So based on these, what are the possibilities that you can make out? So A to F, what is the answer they have asked you to pick up? So here is the pathophysiologically to see here. So acute respiratory acidosis will be somewhere here. This is chronic respiratory acidosis. That's what our patient is having. So the answer here is B. So patient is having B. 28-year-old bilateral adrenal masses, there is cerebellar hemangioblastoma and kidney cyst. And you see that there is epinephrine is associated. So this is a pheochromocytoma that we are dealing with, as well as this patient has von Hippel-Lindau's disease because there is hemangioblastoma kidney cyst. So what is the mechanism here? So von Hippel-Lindau disease, please remember, there is a impaired HIF degradation. So answer is B here. That is why cysts are formed. So hypoxia-induced factor is not getting degraded, and that is the reason why you have this cyst and tumors that is getting formed. What is classical against regarding headache is wrong about this. So cluster headaches, unilateral orbital temporal, that's fine. Paroxysmal hemicronia longer than cluster headache. Sunc-city, short and frequent. All trigeminal autonomilia will have autonomic features. So first one is definitely right. Last one is definitely right. Now you have option between the two. Please remember Sunc-city is also short. One thing you have to remember, paroxysmal hemicrania is not longer than cluster. So if you look at the cluster duration is between 15 to 180 minutes, whereas paroxysmal hemicrania maximally lasts for 30 minutes. That's there. So that's something that you have to remember. Please remember these tables. What are the triggers and how do we treat? And that's the right option. Patient has been experiencing a seizure. Laboratory shows the serum osmolality is 270. Urine osmolality is 1000. So urine osmolality is much higher than the serum osmolality. What is the abnormality that you expect? Very, very important. It is hyponatremia. So hypovolemic hyponatremia, that is what you get. 62-year-old, increasing fatigue. There is confusion, nausea, depression, hypertension, neuropathic pain. She's on sertraline, carbamazepine, and amlodipine. She's mildly confused. BP is okay. You find that there is sodium is low. And again, you see here the serum osmolality is urine osmolality is higher than the serum osmolality. Urine osmolality more than 55. This is classically fitting into a syndrome of inappropriate ADH secretion. Now, why this patient has gone into that? Possibly due to the drugs. Carbamazepine is notorious to get that. So the answer for this is B, ADH secretion. That is what is producing the hyponatremia. So here you can see that there is a patient who's having a classical high steppage gait. You can see that steppage or the stamping gait. He's really like touching the entire ground. Spastic paraparesis. It is macrocytic anemia. All these are fitting into vitamin B12 deficiency and subacute combined degeneration of the cord. So what's the treatment? So vitamin B12 has to be treated before folate correction. Please remember, if you correct folate before vitamin B12, the neurological manifestations can worsen. So B12 has to be supplemented before folate to be corrected. Elderly patient, slowness of movements, rigidity in one hand, and you can see this classical pill rolling tremors. So you know the diagnosis is very characteristic. That is Parkinson's disease that you're doing. She has asymmetrical onset, good response to levodopa, which is the best to say this patient is having Parkinson's disease rather than atypical. So please remember the order of symptoms, TRAP. So tremor, rigidity, akinesia, postural instability. This is classical idiopathic Parkinsonism. Idiopathic Parkinsonism is asymmetrical in onset, good response to levodopa. So if you see here, C option is the best answer for correct idiopathic. Absence of tremors is a feature of secondary Parkinson's. Early postural instability and frequent flaws is secondary Parkinson's, either progressive supranuclear palsy or Scheidrager syndrome. Symmetric onset of rigidity again is not a feature of this. It could be CBD or it could be some other disease. So asymmetric onset starts with tremors, good response to levodopa is characteristic of idiopathic Parkinson's. Respiratory distress, biphasic stridor, and you can see this classical steeple sign. It's a very pathognomonic laryngotracheal bronchitis is the answer for this. 9-month-old, this is the motor activity the child is doing it, is able to perform gross motor activity while holding on to furniture. So what is the correct statement? So this is appropriate for the age. So this is an appropriate milestone. So B is the answer for this. 8-year-old, abdominal pain, vomiting, periorbital puffiness after chemotherapy. There is hyperuricemia, creatinine elevated, hyperkalemia. You know this diagnosis is tumor lysis syndrome. So these drugs are used for tumor lysis syndrome, but out of this, the most important is hydration. So answer D is correct. All the rest is correct. But the first thing that you have to do is hydration so that the uric acid, calcium, everything can get excreted. National vitamin A prophylaxis, what is the correct administered? So 9 months, 2 lakhs, 15 to 20, 18 months, 1 lakh with DPT booster, 9 months, 1 lakh with measles, and 24 months, 1 lakh. Please remember, all of you know this, 9 months, 1 lakh with measles vaccine is the correct option. Height for age more than 2 standard deviation below. What is this? So it's a chronic malnutrition. So it says height for age, stunting is happening. And it is significant. So it's a chronic malnutrition that's there. 6-year-old, clitoromegaly, early development of pubic hair. She has no history of salt wasting. And urine shows elevated androgen with mildly increased progesterone. Serum electrolytes are normal. So remember, serum electrolytes normal, no salt wasting. It is not of the important adrenal, not the main deficiencies that is there. Neither it is a salt wasting. So this is wrong. 21 hydroxylase is wrong. Congenital adrenal hyperplasia is wrong. So just virilization is happening. So this is a simple virilizing hydroxylase deficiency. Child has this ECG. You can see the narrow complex regular tachycardia. Your answer is SVT. So PSVT drug of choice is adenosine. The dose in adult we give is 6 milligrams. So here the dose is 0.1 milligram per kg. That's the correct. Now, very importantly, this is done if the BP is stable. If the BP is not stable, we will have to cardiovert it. That's not given in this MCQ. HIV primigravida, viral load is 1200 copies, delivers a baby. What you do? So remember, the copies is more than 1000. So you have to give treatment for the baby also. So nevirapine syrup with zidovudine combination with the breastfeeding. Breastfeeding cannot be stopped. If it was less than 1000 copies, maybe you would have given a single drug, but it is more than that. So you will have to give double drugs and exclusive breastfeeding. You can't stop the breastfeeding. Answer is A. So this is how you do it. So check the child's HIV PCR after 6 weeks. If it is positive, then you will have to continue the treatment. Otherwise, you can stop. 5-year-old, skeletal deformities are there. You can see the gross skeletal deformities. Normal intelligence, that's very important. And urine glycosamino analysis is showing keratin and chondroitin sulfate. So you know it's a lysosomal storage disorder. Corneal clouding is present. So which one? Very, very characteristic. This is the Marquez syndrome. So please remember the Marquez syndrome and the Montreux Lamy, the intelligence is normal here. So that's very important. And they'll have co-species, they'll have joint contractions and visceromegaly. Visceromegaly is not there in this patient. That's why it becomes Morphew. And developmental is something which is not seen. The other ones, please remember this table, will have the other features that could be associated. Sudden, brief, involuntary myoclonic jerks in a 16-year-old girl. And you can see the polyspike slow and waves that you're seeing here. What is this diagnosis? So very, very specific pattern of juvenile myoclonic epilepsy. JME is one. So this would not respond to treatment with the antiepileptics, might require surgery. So JME is the important one that you see. 30-year-old heroin addict comes with lacrimation, rhinorrhea, pyeloerection, mydriasis, muscle cramps, and anxiety 10 hours after the last course. So what is the mechanism? Obviously, this is the withdrawal mechanism that you're seeing here. So is it dopaminergic? Is it GABAergic? It is cholinergic? Is it compensatory? Noradrenergic. So remember, this is the compensatory noradrenergic hyperactivity. Okay, because dilated pupil is seen. 32-year-old is sexually proactive, seeks attention, speaks vaguely and emotionally, and displays shallow, rapidly changing emotions. A 35-year-old has grandiose lack of empathy and expects special treatment and becomes enraged in criticism. So what sort of personality he has? He has a narcissistic personality and sexually provocative and seeks attempt for that. This is a histrionic personality. So remember, woman has a histrionic personality disorder. The man has a narcissistic personality disorder. So these are the very, very characteristic features that you see in a histrionic and a narcissistic personality disorder. Please read about the other personalities. You will get 1 or 2 questions on that. 32-year-old treatment-resistant major depression. You have earlier they used to give electroconvulsive therapy. Now you have new drugs which have come up against the NMDA receptor. So what is it? So is it brexanolone? Is it esketamine? Is it lurasidone? Is it lemborexant? So please remember the drug that we have for depression acting on the NMDA receptor is the esketamine. The other drugs, brexanolone is used for postpartum depression. It is GABA modulation, not NMDA. Lurasidone is an atypical antipsychotic. It's not used in depression. It is acting through NMDA, but it is not used in that. And the lemborexant is a dual orexin receptor used for insomnia, not for depression. 38-year-old schizophrenia says, Doctor, I went to the mall. Voice in my head speaks my thought aloud. I think to myself, I'll buy shoes. And immediately a woman's voice says exact same word. So very, very, very characteristic. This is a third person, third person hallucination you're getting. So it's a running commentary. Is it third person? Is it thought insertion? It is Jenden-Kennel burden. So this phenomena, that what patient is thinking, coming back to the person itself, is classically what we call it as the three auditory hallucinations, the third person hallucination. This is the very, very characteristic. You have voice having a running commentary and then the audible thought. This is the phenomena which you're seeing in this patient. Decoder pense. It means patient hears his own voice aloud. So that is what we call it as audible thought. So these are three Snyder's first rank symptoms that you see, 3 types of hallucinations that you know. So this image very characteristically, you're seeing rhinoderma, which is characteristic of vitamin A deficiency. So rhinoderma is vitamin A deficiency. Painless lesions which have healed very characteristically. So painless lesions in the glands, you're suspecting syphilis as the cause. And what is the organism? So you can see here, A is characteristically syphilis. This is your leptospira. This is H. pylori. And this is the triphorema that is there. So the answer for that is A. It's the silver staining that you're seeing. 72-year-old, multiple tense blisters on the thigh. And what is the classical sign? So it is the classical sign that is described as the bulla spread sign, classically seen with bullous empty. Auspitz sign and Nichols-Lee sign can be seen in both. Auspitz sign in psoriasis, dimple sign in case of neurofibromatosis. 25-year-old, rifampicin therapy for tuberculosis, and she's starting using OCPs. What's the problem with OCPs? Very, very important. Rifampicin is an enzyme inducer. So OCP failure will happen. So answer is C. 45-year-old emergency department, vomiting, abdominal pain, hypotension, altered sensorium. BP is low. There is severe dehydration and he's been taking corticosteroids. So remember, this is an acute Addison's crisis. Acute adrenal crisis that you're seeing. The drug of choice is hydrocortisone. So you're giving hydrocortisone 50 to 100 milligrams IV bolus. So here oral will not work. So oral hydroxyl is wrong. So equivalent to 50 to 100 of hydrocortisone is dexamethasone 8 to 16 milligrams. So please remember, dexamethasone 8 to 16 milligrams is the answer. Not Fludro, not IM. It has to be IV with saline. Patient receiving digoxin, potassium, clarithromycin, atenolol, and trimethyl has worsening atrial fibrillation. So patient is already on treatment for atrial fibrillation, but means the digoxin levels are going higher, so shows elevated digoxin levels. Now, which of the most drugs is causing it? Is it trimethyl? Is it atenolol? Is it clarithromycin? Is it potassium chloride? So potassium the patient is or not. So these three are the drugs which we are seeing. So among this is the clarithromycin is the one which is directly responsible for elevated digoxin level. Which of the following explains the selective action of acyclovir on herpes virus? So herpes, please remember, acyclovir is a pre-drug. It has to be converted into the active molecule by using the viral thymidine kinase. This is the specific. That is why it is specific for herpes. So answer is C. Rickets patient, calcium was low, phosphorus is okay there, vitamin D was less. Started on high dose vitamin D, and after 2 months comes with vomiting, polyuria, fatigue, calcium is gone up. So hypercalcemia after vitamin D. So the diagnosis here is possibly because of vitamin D toxicity due to the overdosage. To stop the vitamin D, hydrate the patient will improve. It's not because of anything else. Sodium promoglycate, remember it's a mast cell inhibitor. It's a mast cell inhibitor that's used, and it is used inhalationally. So it's not used orally. So oral is gone. It does not use effective. It's not an acute bronchospasm that, and not beta 2. So the answer for this is C, inhalation, and it is poorly absorbed orally. So it is inhaled route you're giving. 20-year-old, 60 kgs, fever, chills, rigors, Plasmodium falciparum, northeastern, so chloroquine resistance. So remember the treatment is artesunate combination therapy. So you're going to give artesunate with sulfadoxine pyrimethamine. That's the mainstay therapy. And it is falciparum, so you're giving primaquine also. So the answer is B. That's the National Malaria Program. Which of the statement is true about ARBs? Losartan acts on thromboxane A2 and inhibits platelet aggregation. Candesartan should be reduced in case of liver failure, not in renal failure. Irbesartan should be decreased in hepatic failure and renal failure. Rosuvastatin should be reduced in renal failure, but not in hepatic failure. The most specific thing, please remember, always losartan has additional thromboxane A2 inhibition and produces platelet aggregation. The rest of them are partly correct, but the first statement is definitely correct. Severe muscle weakness, drooping eyelids, and difficulty in swallowing, and cholinesterase admission improving. So please remember, this is myasthenia gravis. GB won't improve, botulism, Lambert-Eaton will not have ptosis. Myasthenia gravis. So it's a fatigable weakness. You have neuromuscular junction and you're giving cholinesterase inhibitors, neostigmine, pyridostigmine, and the patient improves. 6-month-old, severe respiratory distress. You find diffuse crackles, nasal swab is positive for RSV. What is the drug of choice? Ribavirin. RSV, the drug of choice is ribavirin, nebulized or inhaled. 26-year-old, severe menstrual cramp, heavy menstrual bleeding is there. So dysmenorrhea, what's the drug? So pain is there as well as there is increased bleeding. The main drugs would be an NSAID with prostaglandin F2 alpha. 40-year-old on hydrochlorothiazide develops renal stones. Now, what is the reason for that? So renal stones is not due to hypercalciuria, it is due to the decreased citrate. Citrate is a inhibitor of stones, so decreased citrate excretion. So answer is A. High proportional mortality rate for communicable disease in the country likely indicates what? Improved diagnostic facilities, aging population, high burden of preventable disease, and high life expectancy. Please remember, mortality rate is a high burden of preventable deaths. Demographic study, the net reproductive rate is less than 1, while the total fertility rate remains 2. What does it indicate? So this means that the daughters born per woman is below the replacement levels for the female mortality. Mortality is higher, but the B is the option for this. So that's the correct answer in this case. Clinician reveals that smoking causes malignancy 8:1 odds ratio. So what does that mean? So remember, odds ratio is going to say that this many high chance. So smokers have a 8 times higher chance of developing cancer. That's the answer. Odds ratio just says this. A study noted onset and duration of cholera between this. What are the number of the cases were used to calculate the prevalence from Jan 1st to 31st? So Jan 1st is here, 31st is here. So whatever cases happened before that, so you can see 1, 2, 3, 4, 5, 6. So 6, 7 is after that. So here answer is 6. So 6 cases are used for prevalence. A malaria control program shows rising resistance for both HCC and this one. So what is the approximate next step? So there is resistance, so we will have to switch to other drugs. And the most potent ones that we have is organophosphorus and carbonates. Child has streptococcal infection, that means acute rheumatic fever without carditis. So you will give penicillin up to the age of 18. That's the treatment. Every 3 weeks for 5 years or until 18. If there was carditis, it would be lifelong. Now here, surveillance of chlorinated, 2 laboratories showed residual chlorine, but differ in the assessment of free chlorine. One laboratory used orthotolidine test, while the other one used orthotolidine arsenic test. Which feature of OTA is better? So please remember, OTA can specifically determine free and combined chlorine. That is why it is better. High concentration of BPAP that is seen. So what pollutant it is? It is a polycyclic aromatic hydrocarbon. So that's what you see in the, it's a polycyclic. Very common AgMark. What does AgMark say? It sees that this meets quality of standards of agricultural. So AgMark is just for the quality of the standard. 10-year-old fever, myalgia, and you can see the classical Aedes mosquito. So please remember, Aedes is a daytime biter. That's something you have to remember. Most likely characteristic here they have given is daytime. So that's the answer of Aedes dengue the patient is suffering. 2 data sets, same mean but different values of this one. So what is it? So this says dispersion. So mean central tendency is a measure, but 2 different sets are having different values. So possibly the spread of values is due to dispersion. That is what you're making. During the environmental survey, these instruments are used. So which one is going to use the air velocity? Please remember, air velocity is the Carta thermometer, that is C. So Carta thermometer is the one which is used for air velocity temperature. Community survey, 30% of children have less than 5, 20 is wasted, 15 is under 5. What is the global hunger index? So global hunger index is calculated by adding all and dividing by 3. So the answer comes as 21.7. So the answer is A. 21.7 is the answer for this. SI unit for brightness emanated by a point light source is candela. 480 individuals, 60 of them who have a disease, out of which 50 turn positive, 20 who do not have a disease turn positive. So what is the sensitivity of this test? So if you put into the label, so 50 and 10 here, 20 and 400 here, and then you can have the values that are going to be predicted in these patients here. So true positives is what we are worried about. That is A by A plus C, that is 50 by 60 per 100. So the answer for this is 83.3%. That's the true positive we are looking for. Earthquake, densely populated city, the team has to manage. In the first 72 hours, what is the thing they have to do? Please remember, in the first 72 hours is only rescue, emergency aid. So answer is B. All the rest is later. So you are going to do the emergency rescue and scare. That is the first thing that you're doing in the first 72 hours. Now, rule of halves, hypertension, you know, that is only 50% are diagnosed, 50% are treated, 50% are controlled. So 10,000 adults, they found a 40% prevalence. What of the total population are treated but inadequately treated? So you know the formula, total is 10,000, so 40% is 4,000, out of which 2,000 will be aware, 2,000 won't be aware. Receiving treatment will be 50% of the 1,000 only. Adequately controlled will be 500. So treated but not adequately controlled is 500. So 500 divided by the total population, your answer comes as 5%. WHO stepwise approach includes all except, it's very, very important, physical, psychological, behavioral. There is preventive aspect but not therapeutic. So preventive is there but not therapeutic. Neonate has history of fasting hypoglycemia, low glucose, low insulin. Most common, please remember it is GLUT2. So GLUT2 is the answer here. So children with coming with these abnormalities, you're looking at GLUT2 as an effect. So the various glucose transmitters and their various features you have to know. Which of the following statements best describe the role of functional complex 1 in the mitochondrial? So please remember the functional complex 1 is accepting NADH and then transfers the CoEQ and 4 protons. So the answer is B. 10-year-old boy, xanthomas, family history is present. Cholesterol is 480, triglycerides is 160, 146, LDL is high, HDL is low. Which type of hyperproteinemia you're looking at? So please remember where you have the levels of cholesterol being very high. So it's a familial hypercholesterolemia that you're looking at. So possibly this patient is having a type 2A, that is what is very characteristic, where you have xanthomas and xanthelasmias, which are very characteristically seen in these patients, and family history of coronary artery disease is there. Newborn hyperammonemia and the elevated citrulline levels. The enzyme is very, very characteristic. ASS, that is the arginine succinylcyanide synthase deficiency. Now, which of the following is incorrect about bile pigments? Ehrlich detects bilinogens, gives red color. Fauchet's gives ferrichloride, detects bilirubin. Gemlin detects bilins with green fluorescence, and Schelsinger detects bilin with zinc ion complex. Please remember the Schelsinger is the one which is using fluorescence and not Gemlin. So if you look at the various tests, so Fauchet's, Gemlin, and Vanderberg's is going to detect the bilirubin, not the bilinogens, not the bilins. Ehrlich is going to detect the bilinogens, and Schelsinger is going to detect the bilins. So please remember, and fluorescence is bilin is classical of Schelsinger, not Mellin's test. 8-year-old vomiting diarrhea after taking this fungus, Amanita. So Amanita foliates will inhibit the RMA polymerase. So that's something that you have to remember. OPD, loose stools, nausea, vomiting, rashes over the sun-exposed areas. So you have the classical castle's necklace sort of feature, the vitamin deficiency that is classically produced. So this is niacin deficiency, and the disease we are talking is pellagra. So pellagra with niacin deficiency is the characteristic option that you have in this patient. So students, in today's session, we discussed the multiple choice questions which are related to medicine and allied subjects. And we discussed the options. We discussed how do we narrow down to these options and how do we specifically localize the correct option. Hope this session was useful. Thank you.
Okay, so hi everyone. I hope you would have given the test and you're really very close to your exam now. It's just 20 days, I guess, which are left. So I'll be very quick through the session. The important points only I'll be discussing. Those who have joined, I hope you'll be getting something good out of the session. And those who can watch it later, it will be better to watch it later. Okay, so we quickly swift through the questions that were asked. Only the key pointers will be discussed. No very elaborate discussion because we've already done majority of our discussions. Okay, all right. So what was the first question that was asked? The first question, so I'll be covering the share of questions which are mainly related to surgery and the allied aspects, okay? So a 40-year-old man presents with a traumatic ulcer over the medial aspect of ankle. After adequate debridement and the development of healthy granulation tissue, a wound coverage is still live. So after adequate debridement and the development of healthy granulation tissue, वुंड कवरेज प्रोसीजर इज प्लान। तो आपको क्या दिख रहा है बेटा, एक वुंड है, ट्रोमेटिक अल्सर था उस पेशेंट को, अब ये वुंड आपको दिख रहा है, डिब्राइडमेंट के बाद आपको यू कैन सी अ हेल्दी ग्रैनुलेशन टिश्यू। The question that is being asked is which of the following instruments is most commonly used for this procedure? तो आपको पहले तो प्रोसीजर समझ में आना चाहिए कि प्रोसीजर क्या करोगे आप। So what are you going to do in this case? You'll be doing a split thickness skin grafting, okay? So that is what you will be doing here in this patient. तो क्या करोगे आप इसमें, which is the device which is used for this purposes? You use basically a Humvee's knife. तो Humvee's knife हम use करते हैं, and nowadays we also have started using the powered dermatome. Okay, so this was what the question was asking. So this is your Humvee's knife, right? This is your Humvee's knife. And this is your powered electrical dermatome, and you should be able to identify both these instruments in the examination. Okay, so this is your powered dermatome. All right, okay, so this was the first question. It was a pretty straightforward and easy question. Next one was the instrument demonstrated in the video is used in the management of certain intestinal conditions. Which of the following statements regarding its clinical applications is incorrect? पूछा है, पहले तो इंस्ट्रूमेंट आइडेंटिफाई करना है. What is the instrument looking like? This is बेटा a flatus tube, ठीक है? तो ये आपका characteristic flatus tube है. अब फ्लैटस ट्यूब में आपको आगे केवल एक लैटरल आई भी मिल सकती है. द डिस्टल टर्मिनल ओपनिंग कैन बी, टर्मिनल एंड कैन बी ओपन आल्सो. तो बोथ द टाइप्स ऑफ फ्लैटस ट्यूब्स आर अवेलेबल, ठीक है? इसमें उसने टर्मिनल एंड को क्लोज दिखाया है, बट यू हैव फ्लैटस ट्यूब्स वेयर द टर्मिनल एंड आर ओपन आल्सो. So what is incorrect? It is passed per rectum to decompress the bowel in uncomplicated sigmoid volvulus. Keyword is uncomplicated. So therefore it is a correct statement. ठीक है? Uncomplicated sigmoid volvulus में हम उसको decompress करने की कोशिश करते हैं. So we pass a flatus tube. There's a lateral eye through which the gas flatus as well as the feces can pass out. Okay, so that is one thing. It has a tip with one terminal opening and a side hole proximal to the tip. That's a true statement. Its use can completely prevent the need for surgical intervention in gangrenous volvulus. Absolutely false. This is a false statement. अगर gangrenous volvulus हो चुका है बेटा, तो आपको क्या करना पड़ेगा, अंदर जाके उसको जो gangrenous portion है उसको आपको resect off ही करना पड़ेगा. I've told you a general principle across surgery. Anything which is necrotic or gangrenous cannot be left inside the body. उसको आपको निकालना ही, आप उसको अंदर नहीं छोड़ोगे, ठीक है? So you will not be putting in a flatus tube in these cases. The main procedure that is going to be done is mainly surgical resection that has to be done. So therefore, this is incorrect. It is used to relieve abdominal distension and subacute intestinal obstruction of paralytic ileus. Yeah, with a large bowel, it's a colonic obstruction. So you can definitely use it there as well. So the answer here is option number C. Okay, so that is the answer for this question. Next question. Which of the following suture materials is non-absorbable? Non-absorbable पूछा है. तो polybutester, polyglactin, that is Vicryl. This is your Vicryl, right? Polydioxinone, that is PDS, and polycryptophan, that is monocryl. इसमें से क्या क्या है बेटा? These ये सारे क्या है आपके एब्जॉर्बेबल सूचर्स हो गए. एक ही है जो नॉन एब्जॉर्बेबल है इनमें से, दैट इज पॉलीब्यूटास्टर. ओके, पॉलीग्लैक्टिन वाइक्रिल इज गोइंग टू बी ब्रेडेड मल्टीफिलामेंट. बाकी आपके सारे क्या है बेटा, दोज आर ऑल, रेस्ट ऑफ देम आर मोनोफिलामेंट। तो ये आपको पता होना चाहिए, सूचर्स वाज डिस्कस्ड elaborately in our sessions also, so you should not be getting this question wrong. A quick revision of the sutures. Amongst the absorbable sutures, the natural ones are catgut, both plain as well as chromic. Synthetic ones which are absorbable are polyglactin 910, that is your Vicryl, polyglycolic acid, that is Dexon, PDS we have already talked about, and polyglycaprone is your monocryl, also glycomer 631. Amongst the non-absorbable ones, which are the natural ones, we talked about the silk, cotton, and linen. Synthetic कौन-कौन से होते हैं जो कि non-absorbable है? One is your nylon, most important, polyamide or nylon. You can have proline, you can have polyester, and also what is asked in the question, that is polybeta ester, as well as your PVD, that is polyvinylidene fluoride, ठीक है? And also your surgical suture, stainless steel that we use in surgery, that is also a non-absorbable. ठीक है बेटा? Okay, so that was this question. Next question. A 40-year-old male is brought to the emergency with burn injury. ठीक है, 40-year-old patient है, burn injury के साथ आया है. अब burn injury कहाँ पर है? Front of right side of the face. तो ये आपका face है, front of the right side of the face. तो half of the face is involved. ठीक है, आधा face गया है. फेस का हम क्या बोलते हैं बेटा? इट इज 4.5 4.5 आगे पीछे, तो टोटल 9 होता है. So out of 4.5, this is what 2.25% roughly. Right side of the front of the neck, so head and neck entirely is 9, तो आपका neck भी इसी में component में include हो गया है. We are calculating as per the 9 formula, ठीक है? Okay. Front of the right side of the chest and abdomen, तो overall हम क्या बोलते हैं? 18 18 18 18, so half is going to be 9. So for the chest and abdomen हमने क्या बोला? 9% आपका ये add हो गया, ठीक है? Then फ्रंट ऑफ द राइट अपर लिम, अगर राइट अपर लिम की बात करेंगे, आगे पीछे मिला के 9, तो आगे की तरफ वो बोल रहा है फ्रंट, तो 4.5% इसका हो गया. एंड द फ्रंट ऑफ द राइट लोअर लिम, दैट इज हाउ मच? दैट इज अगेन 9, ठीक है, तो वो भी 9% हो गया. तो कितना हो गया कैलकुलेट करके? 9 + 9 18, 18 + 4.5 is 22.5, and that is 2.25, that is roughly 24.75, so that is going to be 25%. Okay, all right, next. तो ये आपका रूल ऑफ 9 है जो हमने इसमें फॉलो किया. यू ऑलरेडी नो दिस, सो वी क्विकली बी मूविंग ऑन टू द नेक्स्ट वन. A 50-year-old male with cardiac arrhythmia was brought to the nursing home. ठीक है, 50 साल का मेल है, cardiac arrhythmia के साथ nursing home में लाया गया है. ECG हुआ, क्या मिला? Shortened QT interval, very very important. That's the first important finding. Prolonged PR and QRS intervals as well as increased QRS voltage, which can lead to cardiac arrest. Which of the following is most likely? So whenever you talk about shortened QT, that you are talking about hypercalcemia basically. So this is hypercalcemia. What is happening here? Basically the ST segment is being shortened. So ST segment is being shortened, so overall QT shortening will also be there. If you are talking about the prolongation of QT, that is generally a feature of hypocalcemia, right? So this is what you should be knowing. Here you get the prolongation of QT. So this is prolonged QT. In hypokalemia, you get characteristic that the U wave and there is prolonged QU interval. So there is prolongation of QU. तो ये आपको पता होना चाहिए by now. It is all something that you should have known on your tips. ठीक है बेटा? So when you talk about hyperkalemia, you get the tall tented or peaked T wave. This is what is the characteristic principle finding there. Hypokalemia, it's U waves as well as prolonged QU. Hypercalcemia, you get a short QT. Basically, it's a short ST that we can write a short QT as well. And in cases of hypocalcemia, you get long QT. Okay. So this is what was there in the question as well. Next question kya tha? Let's read through the next question. It's a big question. A 54-year-old man is brought to the emergency department with dizziness and weakness. Okay. He reports 3 days of profuse watery diarrhea and poor oral intake. Diarrhea ho raha hai aur intake bhi kam hai. On examination, he appears ill and anxious. Extremities are cool to touch. Capillary refill is delayed. Lung examination is clear. No evidence of external bleeding. So bleed ruled out ho gaya hai. That is one thing. Peripheries are cool to touch. Capillary refill delayed. Vital signs में टेम्परेचर कम है पेशेंट का, हार्ट रेट बड़ा है मतलब टैकी है, ब्लड प्रेशर कम है, वेरी इंपॉर्टेंट, हाइपोटेंशन, रेस्पिरेटरी रेट इज 22, Serum sodium is almost normal, BUN is elevated, creat is आपका बढ़ा हुआ, lactate is also increased. So what are these characteristic findings of shock? Lactate बढ़ा हुआ है, shock के features हैं क्योंकि पेरिफेरीज आपकी कोल्ड है, कैपिलरी रीफिल डिलेड है, टैकीकार्डिया है, साथ में हाइपोटेंशन है. What is the kind of shock that you have? You have hypovolemic shock. राइट, डायरिया हो रहा है पेशेंट को, इनटेक कम है, बट इट इज नॉट हेमोरेजिक काइंड ऑफ शॉक. ठीक है, क्योंकि नो एक्सटर्नल ब्लड लॉस इज हैपनिंग. सो व्हेनेवर यू हैव हाइपोवोलेमिक काइंड ऑफ शॉक, ये क्यों बढ़ रहा है बेटा? बिकॉज ऑफ द पुअर रीनल परफ्यूजन. रीनल परफ्यूजन कम हो रहा है तो क्या हो रहा है? देयर इज एक्यूट किडनी इंजरी. दिस इज प्री रीनल AKI दैट वी आर बेसिकली लुकिंग एट. So what is being asked? What is the most appropriate initial management of this patient? Would you administer norepinephrine infusion? अच्छा, norepinephrine infusion vasopressor हम देंगे क्या बेटा? सुनो, hypovolemic shock है, vessels के अंदर fluid कम है. Whenever you have less fluid, is there any point of compressing the vessels? No. The first prerequisite for giving vasopressors is to have adequate volume in the blood vessels. So therefore, this is not the initial management. Transfuse packed RBCs, no, there is no point. आप hemorrhagic नहीं है, there is no blood loss that has happened. What you need is fluid resuscitation. What are you going to give? Isotonic crystalloids. क्या दोगे? This is what you're going to give. Basically, we'll start with Ringer's lactate. Broad spectrum IV antibiotics can be given later. Direct history there, but it's not going to be the initial management that you are basically going to look at. Okay, so that was this question. Next. Again, this is something that we had discussed in our sessions also. A patient with compound fracture and degloving injury who is stable, keyword, stable hai, compound fracture degloving, but needs care within hours, is categorized under which triage category? क्या होता है बेटा? अगर immediate care चाहिए, stable नहीं है, तो अब तो हम क्या बोलते हैं? Red category. If he is stable, he needs care, but it is not immediately life-threatening. That is what falls under the yellow category. वैसे भी हमने आपको एक पूरा चार्ट दिया था, which is there in the 20th edition of Bailey Law, which is characteristically important क्योंकि उसमें बहुत सारी इंजरीज हैं जो लिस्टेड है. अब इसमें एक चीज और ध्यान रखनी है, यहीं पर अगर वो बोलता कि कंपाउंड फ्रैक्चर डीग्लविंग इंजरी विथ मैसिव एक्सटर्नल हेमरेज, अगर यहीं पे मैसिव एक्सटर्नल हेमरेज ऐड कर देता तो देन इट वुड हैव बीन अ रेड कैटेगरी. सो देयरफॉर ये आपको समझ में आना चाहिए. सो लेट्स क्विकली लुक एट दोस इंजरीज बेटा. दिस इज एन इंपॉर्टेंट कांसेप्ट विद से क्वेश्चंस आते हैं. सो इफ देयर इज अ सिवियर फेशियल ट्रॉमा, if there is a tension pneumo, anything which is threatening the life immediately, where there is immediate medical need that is needed, that is required. Profuse external bleeding. So if you are having any fracture, any injury wherein there is profuse external bleeding, there is an exsanguinating external hemorrhage. आपको sequence भी पता है. It is XABCDE now. It is not ABCDE. Exsanguinating external hemorrhage management has the top priority as per the 11th edition of ATLS. Okay. Major intra-abdominal hemorrhage or EDH. These are the cases of all red category in the triage. Okay. Yellow category is when medical need is urgent but can be temporarily delayed. It's critical but they are likely to survive if the treatment is slightly delayed. क्या क्या आता है? जैसे कि हमने डिस्कस किया, compound fractures will be there. Degloving injuries, very important. This was what was discussed as a question in our discussions. Ruptured abdominal viscus is going to be yellow category. Why? Because it is not saying that any vessel has been injured. Abdominal viscus has ruptured, peritonitis is going to develop. It's a critical condition, but not immediately life-threatening. That is why you have to understand it, okay? Pelvic fractures and spinal injuries. When you talk about the green category, these are the non-urgent or the minor ones that we are basically talking about. They are stable and they can survive if the treatment is delayed for hours to days also. So basically consider simple fractures, sprains, and minor lacerations in this category. Last, obviously, is the black category, whether expectant or unsalvageable patients. No breathing, pulselessness, devastating brain injuries, extensive burns, major crush injuries, all of that falls under the black triage category. ठीक है बेटा? चलो, okay. Next question. A 34-year-old patient presents with a high-speed motor vehicle collision. He was wearing a seat belt. Seat belt उसने पहनी हुई थी. He is hemodynamically stable. Keyword, hemodynamically stable है patient. That's very important. Examination shows a transverse ecchymosis over the lower abdomen. अब ये कौन सा साइन दिख रहा है आपको? ट्रांसवर्स ecchymosis. This is known as the seat belt sign. जहां उसने सीट बेल्ट पहनी है वहां पे उसको ecchymosis हुआ है. Fast is negative. Fast कर चुके हैं, fast negative है. Which of the following is the most appropriate next step in the management? Now, what can happen here? Basically, आपका fast negative है, but will you just be relaxed after the fast is negative? No, because fast is going to tell you about the fluid which is present in the cavity. अब fluid नहीं हो सकता है, क्या क्या चीजें हो सकती हैं? Seat belt syndrome. So we basically are now considering with the seat belt syndrome. ये हमारी टेंशन है. क्या तीन चीजें हम देखते हैं बेटा सीट बेल्ट सिंड्रोम के अंदर? वन इज द सीट बेल्ट साइन जो यहाँ पे मिल रहा है, दैट इज इकाइमोसिस जो हमको दिख रहा है. सो इकाइमोसिस इज विजिबल. प्लस वी टॉक अबाउट इंट्रा एब्डोमिनल इंजरी, राइट? सो दे कैन बी इंट्रा एब्डोमिनल इंजरी. क्या क्या इंजर हो सकता है? बावल या होलोविस्कस की इंजरी हो सकती है, और दे कैन बी इंजरी टू द मेसेंटेरी. यू कैन हैव मेसेंटेरिक हेमेटोमा. Plus, what do you have? You have the lumbar chance fracture, right? You have lumbar chance fracture. तो ये तीन चीजें हो सकती है. Mainly we are concerned now with the intra-abdominal injury. Bowel perforation तो नहीं हुआ है या mesenteric hematoma तो नहीं हो गया है. So what is the next investigation that you're going to do? Patient is stable also. That is when we'll go for CT with the IV contrast. So CT of the abdomen with the abdomen and pelvis with IV contrast. DPL is almost negligible nowadays in use wise. Basically do a CT only. Okay. All right. Next. A 72-year-old man is diagnosed with gastric malt lymphoma, okay, with no nodal involvement. मतलब कौन सा disease है? Early disease की हम बात कर रहे हैं, ठीक है बेटा? On further investigation, urease assay is positive. Urease positive. मतलब what are we talking about? We are talking about the H. pylori infection. ठीक है, H. pylori है. And eventually we also know that H. pylori can predispose to mild lymphomas. What is the first line of management? So whenever we are talking about mild lymphomas because of H. pylori. So how does H. pylori cause mild lymphomas? It leads to chronic gastritis and further inflammation, then on progresses to the mild lymphoma. Early stages of mild lymphomas are very important because it's a continuous antigenic stimulation which is coming from H. pylori that is further leading to the formation of mild lymphoma. So if we move ahead and do a eradication of H. pylori, at times it is noted that the early variants of mild lymphomas can regress. So that's a very good thing. You might not even need surgery. So in the early variants and in majority of the patients wherein you have H. pylori as a causative agent for mild lymphoma, then you give H. pylori eradication therapy as the first line. So H. pylori eradication is the first thing you're going to do in cases of early onset. Nodal disease, then the management will change, but in the early diseases, you can definitely give this as the first line management. Okay? All right. The video shows a defecating proctogram of a 50-year-old man presenting with tenesmus and protrusion of a mass per annus during the defecation. So you can see that there is protrusion that is characteristically visible. Rectal prolapse है. क्या है इस patient को? There is rectal prolapse. ठीक है? तो rectal prolapse patient को है क्योंकि आपको tenesmus भी मिल रहा है, mass protrusion की history भी दे रहा है. Which of the following is the procedure performed in this condition using a perineal approach? It's a very important question. बहुत बार पूछा गया, especially in INI-CT, they ask this question a lot. So perineal approach को बेटा याद रखने के हमारा एक simple सा mnemonic होता है DAT. तीन procedures होते हैं जो perineal approach से करते हैं. DeLong procedures, Altemeyer's, and your Thiers. ठीक है, ये हम तीनों करते हैं. So amongst them, DeLong is what we do. बाकी जो तीन दिख रहे हैं, suture rectopexy, laparoscopic ventral mesh rectopexy, and resection rectopexy, ये तीनों क्या है? These are abdominal procedures. So let's quickly look at the procedures. Abdominal हमने क्या बोला? ये तीन procedures हो गए. Suture rectopexy हमने क्या किया? मोबिलाइज किया रेक्टम को, फिक्स कर दिया किसके साथ? सैक्रम के साथ. वेंट्रल मेश में हमने क्या किया? मेश के साथ हमने फिक्स कर दिया सैक्रम पे. एंड रिसेक्शन रेक्टोपेक्सी में अगर आपका जो सिग्मॉइड था वो रिडंडेंट था तो हमने सिग्मॉइड को रिसेक्ट किया एंड देन वी डिड अ रेक्टोपेक्सी. पेरिनियल प्रोसीजर्स आर डन. कौन कौन से? डुलॉन्ग प्रोसीजर्स की हमने बात करी, वेयरइन वी डिड अ म्यूकोसेक्टमी एंड देन वी डिड अ लाइकेशन ऑफ रेक्टल म्यूकोजल वॉल. दिस इज फॉर शॉर्ट प्रोलैप्स. अल्टमायर में हमने क्या किया? बेसिकली दिस इज फॉर अ लॉन्गर और फुल थिकनेस प्रोलैप्स. एंड फाइनली थियर्स प्रोसीजर जो मैंने आपको दिखाया था बेटा, फर्स्ट इन सूचर लगाते हैं. दैट इज व्हाट इज डन इन केसेस ऑफ थियर्स. ठीक है, so that was about rectal prolapse. Next question. A 45-year-old male presented to the emergency. 45-year-old, okay, young patient presented to the emergency with a complaint of fever and pain in the abdomen. On examination, abdomen was soft and tender in the right hypogastric. Actually, the word should have been hypochondriac region. Okay. CT scan of the examination shows an elevated diaphragm. किस साइड से elevated दिख रहा है बेटा? Right side elevation दिख रहा है आपको. Right sided elevation है. What is the most probable diagnosis? So you can see that there are not multiple. आपको एक main pus cavity दिख रही है यहाँ पर. It is pretty much clear. आपको ये समझ में आ गया कि liver abscess है. आपको ये समझ में आ चुका है बेटा कि ये लिवर एब्सेस है। अब कंफ्यूजन क्या है कि ये पायोजेनिक है कि अमीबिक है। सो वन सिंगल लार्ज pus cavity that you are looking at, abscess cavity that you're looking at, preferably on the right side. हमको क्या पता होता है, amoebic liver abscess, the right lobe is what is preferred. So therefore the answer here is going to be amoebic liver abscess. ठीक है बेटा, चलो next question. A 44-year-old male who presents to the hospital with symptoms of headaches, excessive sweating, chest pain. On examination, BP is elevated, 140 by 95. Elevated levels of fractionated plasma metanephrine. So this is pretty much what? This is pheochromocytoma. ठीक है? कि इसमें आपको कोई दिक्कत नहीं होगी. If you are seriously studying, so you know this is pheochromocytoma. What's the definitive staging gold standard that you're going to do? Which investigation that you're going to do? It's going to be, nowadays I've told you, discuss this, gallium dotatate PET scan, right? Dotatate PET scan, PET CT. This is what we basically prefer, and therefore the answer here is going to be PET scan. ठीक है बेटा? Okay. A 78-year-old male presents to the outpatient clinic with complaints of persistent mild headaches and episodes of vomiting. ठीक है? 78-year-old male है. Now there are features suggestive of raised ICP. Raised ICP के features हैं. There is no recent history of head injury. ICP बढ़ा हुआ है, recent history नहीं है, old male है. On further questioning, son reports that he had a minor fall in the bathroom about 1 month ago, during which he struck his head. He's on long-term warfarin therapy, which was following the mechanical valve replacement. So anticoagulant use. So क्या बेटा? Aged patient, elderly patient. क्या history pointers हैं? Elderly patient. Trivial fall history, trivial fall on anticoagulants. All of these are going to be favoring the diagnosis of SDH. Which type of SDH? Chronic type of SDH. ठीक है? So this is the characteristic pointers that you should be able to identify. ब्रेन में एट्रोफी हो रही है, वेन्स खिंच रही है, ब्रिजिंग वेन्स को खिंचा, ट्रिवियल ट्रॉमा से ब्लीड हुआ, धीरे धीरे ब्लीड बढ़ के बड़ा हुआ. दैट इज व्हाट कॉज द रीजन इंक्रीज इन आईसीपी. अक्यूट होता तो इमीडिएट मैनिफेस्टेशंस आते थे, धीरे धीरे ब्लीड हो रहा था. दैट इज व्हाट वाज कॉजिंग योर क्रोनिक सबड्यूरल हेमरेज. ओके, ऑलराइट, नेक्स्ट. Which of the following statements regarding the therapy shown in the video is incorrect? तो पहले तो वीडियो में दिखा क्या रहा है, let us look at that. So we can see that there is a USG probe which is being run on the lower limb, and you can see that there is a vessel sealer gun which is there. So basically a catheter attached है जिसके एक वीना सील एक गन होती है बेटा, या इसमें ग्लू होता है. Which glue is used? Cyanoacrylate glue is used. So basically a glue is being pushed into the veins. आपकी जो veins हैं, जो veins which are there in varicose veins. Basically it's a treatment of varicose vein that we are discussing here. तो साइनोएक्राइलेट ग्लू से हम क्या करते हैं, जिनकी वॉल्स खराब हो गई उन वेन्स को पुश करके विल सील ऑफ दोस वेन्स. ठीक है, जो आपके जो परफोरेटर वेन्स है उनको हम सील ऑफ करते हैं. अब हम क्या कर रहे हैं यहाँ पे, काम की चीज हमको ये ध्यान रखनी है कि whenever you're talking about glue, तो साइनोएक्राइलेट ग्लू जो होता है, that glue is non-thermal and non-tumescent anesthesia. तो basically आपको tumescent anesthesia देने की जरूरत नहीं होती. क्यों? क्योंकि there is no heat produced. When we talk about endovenous laser ablation or radio frequency laser ablation, there is a heat production. तो इसीलिए क्या करता है, पेशेंट को पेन ना हो इसलिए हम non-tumescent मतलब tumescent anesthesia देते हैं. What is tumescent anesthesia? हाई डाइल्यूशन के साथ लोकल एनेस्थेटिक को डालते हैं तो वो एरिया जो होता है आपका ट्यूमर फूल जाता है वो एरिया. बट दैट इज व्हाट इज नॉट नीडेड हियर बिकॉज देयर इज नो हीट प्रोडक्शन. ओके, सो इट इन्वॉल्व्स इंट्रालुमिनल डिलीवरी ऑफ साइनोएक्राइलेट एडेसिव थ्रू अ catheter two statement. The procedure requires routine infiltration of tumescent local anesthesia along the vein. This is not true. You don't need to infiltrate tumescent anesthesia here. The vein is compressed after adhesive delivery to seal the lumen. Absolutely. आप तो क्या आपने ग्लू डाल दिया, अब कोई भी चीज चिपकानी है तो उसको दबाओगे ना, तो ऊपर से हम कंप्रेस करेंगे. So that is what is done. Consumable costs are currently higher compared to the other venous ablative technique. That is true. Comparatively हम अगर बात करते हैं तो ग्लू की कॉस्ट ज्यादा होती है. ठीक है, so therefore which is incorrect has been asked. The answer is option number D. Okay, next. The surgical approach shown in the video, ये कहाँ से दिख रहा है बेटा? We are basically in the submental region से flap उठा रहा है. Submental या cervical region से या flap उठ रहा है. Is it happening via the lip. Is the lip being split here? No. So this is not lip split. This is your characteristic visor approach that is being. जैसे हेलमेट का वाइजर उठाते हैं वैसे हम यहाँ से पूरा फ्लैप अप का वाइजर की तरह हेलमेट के वाइजर की तरह उसको ऊपर उठाते हैं. This is characteristic visor approach for oral cavity cancers and head and neck cancers में इसको use करते हैं. So this is your visor approach that is seen in this patient. Next, अब ये तो एक नया क्वेश्चन आपके एग्जाम में आएगा. Breast is definitely going to be asked. So let's look at this question. A 42-year-old female presents to the OPD with complaints of painless lump in the right breast. No nipple discharge. On examination, 2.5 into 2 centimeter lump is there in the right breast in the upper outer quadrant, 3 centimeter from the nipple areolar complex. What is the maximum size? It is 2.5 centimeters. ठीक है. तो ये कौन सा T हो गया? 2.5 मतलब less than 2, less than equivalent to 2 is T1. More than 2, but less than 5 is T2. तो ये T2 हमको समझ में आ गया. There are 2 axillary lymph nodes which are seen along with one right internal mammary node. So internal mammary plus axillary. कौन सा हो गया बेटा? This is N3B that you are talking about. What is the staging? So T2 N3B. So this is your answer. This is T2 N3B. So we have discussed this staging बेटा. ये आपको अच्छे से पता होना चाहिए. So tumor which is more than 2 centimeters less than 5. So अपना क्या हो गया? T2 तो यहाँ confirm हो गया. And T staging के बाद N3B हमने क्या देखा? It is having ipsilateral internal mammary nodes along with the clinically positive level 1 or level 2 axillary nodes. So it is N3B. ठीक है, ये staging आपको पता होनी चाहिए. It has been discussed before a lot of times. Okay, चलो next. A 59-year-old male with a 50 pack year smoking history, बहुत लंबे टाइम से स्मोक कर रहा है, presents with severe shoulder pain which is radiating down the medial aspect of his arm. ठीक है, medial aspect of his arm में है. Weak hand grip है, मतलब कौन सी nerve involve हो चुकी है आपके? ulnar. So this is basically the lower brachial plexus that is involved. So involvement of the lower brachial plexus. ठीक है. There is ptosis and meiosis on the right side with persistent cough. तो क्या है ptosis meiosis? Basically we are dealing with the Horner's syndrome. ठीक है, Horner's syndrome भी हो रहा है. Chest imaging reveals the right upper lobe mass. So basically, which of the following structures are most likely directly invaded by this tumor? क्या है ट्यूमर? क्या है? पहले तो ट्यूमर आइडेंटिफाई करो. ट्यूमर कौन सा हो गया बेटा? दिस इज योर कैरेक्टरिस्टिक पैनकोस ट्यूमर. ठीक है, विच इज योर सुपीरियर सल्कस ट्यूमर. ठीक है. What is the syndrome that we get? We have the weaknesses because of the involvement of the lower brachial plexus as well as the Horner syndrome. Why does the Horner syndrome occur? So you have anhidrosis, meiosis, ptosis, and an ophthalmos can also occur. ठीक है. तो ये होता है because of the involvement of the sympathetic chain. Which sympathetic chain? Mainly we talk about the stellate ganglion which is involved, right? So there is involvement of the stellate ganglion. Okay, so this is what is the answer for this question. Next. A prostate cancer detected on truss-guided biopsy due to elevated PSA with no palpable nodule on DRE stage that. तो हमने क्या किया? PSA levels elevated थे. हमने सैम्पलिंग करी, नीडल बायोप्सी करी, हमको क्या मिला? उस पे हमको अगर कैंसर मिल रहा है, that is characteristically a feature of T1C. तो प्रोस्टेट कैंसर की स्टेजिंग बड़ी इंटरेस्टिंग सी है. एक बार देख लेते हैं बेटा in case if the question is asked. So T1, when you say the tumor is not palpable clinically, आपने स्पेसिमेन ट्यूमर के लिए नहीं निकाला था, आपने स्पेसिमेन निकाला बीपीएच के लिए. आपने क्या कर रहे थे? TURP कर रहे थे. सो हमको क्या मिला? इंसिडेंटल हिस्टोलॉजिकल फाइंडिंग. जब भी हम TURP करते हैं तो हमने टिश्यू को भेजते हैं बायोप्सी के लिए. We always send the tissue for biopsy. So when the tissue was sent for biopsy, we found that less than 5% or equivalent to 5% of the tissue that was resected had incidental finding of malignancy, that is T1A. When it is more than 5% of the tissue, that is T1B. And when there is an elevated PSA for which a needle biopsy was done, that is T1C. So tumor identified by needle biopsy, typically because of elevated PSA, that is T1C, and that was what was characteristically asked. T2 का मतलब क्या होता है? Tumor is confined within the prostate. अब T2 में भी A, B, C होते हैं बेटा. If it is involving less than equivalent to half lobe, more than half a lobe, and both the lobes, that is what is T2 A, B, C. T3, when it is extending through the prostatic capsule, it is going beyond the prostate. T3A means extra prostatic extension, which is mainly across the bladder neck. T3B, when it is involving the seminal vesicle, and T4 is when it is going to other structures beyond the seminal vesicle. So what are the other structures that we are talking about? We are talking about the rectum, we are talking about the levator muscles and the pelvic wall. Okay, all right, next. ये क्या था बेटा? So, which of the following procedures is performed using the needle that is shown? So, you can see that there is a curvature that is visible at the tip. This is your 2E needles. Okay, so this is your 2E needle. किसमें यूज होता है बेसिकली फॉर एडमिनिस्ट्रिंग एपिड्यूरल एनेस्थीसिया. सो हमने स्किन पेनिट्रेट करते करते लेगमेंटम फ्लैवम को हमने पियर्स किया. जैसे पियर्स किया हम कौन सी स्पेस में आ गए? एपिड्यूरल स्पेस में. हमने वहां पे कैथेटर डाला तो उसने कैथेटर भी दिया हुआ हिंट के लिए. एपिड्यूरल स्पेस में गए, वी कैन एडमिनिस्टर एनेस्थीसिया एज वेल एज एनाल्जेसिक देयर. सो दैट इज व्हाट is the use of this needle. Next. A 58-year-old male with severe community-acquired pneumonia has been on mechanical ventilation for 10 days. ठीक है, community-acquired pneumonia है, mechanical ventilation for 10 दिन पे, 10 दिन से था. His underlying infection has now resolved. अब समय आ चुका है कि उसको धीरे-धीरे हमको क्या करना है? वेंटिलेटर से wean off करना है. अब ये बेसिकली मीनिंग ऑफ पैरामीटर्स पूछ रहा है कि इनमें से कौन सा फेवरेबल मीनिंग ऑफ पैरामीटर नहीं है फॉर मैकेनिकल वेंटिलेशन. When the tidal volume is more than 5 ml per kg, that is an indication for weaning off from the ventilator. Vital capacity more than 10 ml per kg, that is true. Maximum inspiratory force of minus 15 centimeters of water, no, it is minus 20 to minus 30. This is what we need. It is not minus 15. This is what we need. Okay, this is what is required. Minute ventilation less than 10 is correct, and rapid shallow breathing index less than 100. So less than 105 is what we use. So this is not true. 3 is not true. क्या पूछा है? Not favorable. 1 and 5 favorable. 2, 3, 4. Okay, so the 2 and 4, 3 only is the correct answer here. Okay, so that would be your answer for this question. So let's quickly see the parameters once again. So if the respiratory rate is less than 30 to 35, tidal volume more than 5 ml per kg, vital capacity more than 10 to 15 ml per kg, minute ventilation less than 10 liters per minute, maximum inspiratory pressure जो था वो कितना होना चाहिए? Less than equivalent to minus 20 to minus 30 centimeters of water. Your RSBI जो अभी हमने देखा, that should be less than 105, so less than 100 also. PaO2 कितना होना चाहिए? More than 60. SpO2 should be more than 90. PaO2 upon FiO2 ratio should be 150 to 200 से ज्यादा, right? So FiO2 requirement आपकी कितनी होना चाहिए? Less than equivalent to 0.4 to 0.5. PEEP should be less than equivalent to 5 to 8 centimeters of H2O. So these are your basic requirements for weaning off a patient from the ventilator. Now, what is the maneuver that is being shown here in this video? बेटा क्या maneuver दिख रहा है आपको इसमें? So you can see here that the examiner is tilting the forehead backwards and doing what? And is lifting the chin. So this is your head tilt and chin lift maneuver. This is what is being shown in this video. Now, इनलाइन मैनुअल स्टेबलाइजेशन क्या होता है बेटा? जब दोनों तरफ से उसके नेक को स्टेबलाइज किया जाता है ताकि कोई फ्लेक्शन ना हो. इन सर्वाइकल स्पाइन इंजरीज, दैट इज व्हाट वी डू. दैट इज योर इनलाइन मैनुअल इनलाइन स्टेबलाइजेशन हम करते हैं. ठीक है, सो दैट इज व्हाट इज इनलाइन मैनुअल स्टेबलाइजेशन. दिस इज कैरेक्टरिस्टिकली हेड टिल्ट एंड चिन लिफ्ट. Next question. A 58-year-old woman with sepsis, 58-year-old woman, there is sepsis and renal failure, has received continuous vecuronium infusion for 12 days. 12 दिन से vecuronium चल रहा है उसको, ठीक है? For the management of severe ARDS. After stopping the infusion, she remains profoundly weak and mechanically ventilated for another 48 hours. मतलब despite of stopping the vecuronium, now she is continuously having the same symptoms as if she's on the vecuronium. ठीक है? Most likely mechanism is, तो हमको पता है कि vecuronium जो है उसका मेटाबॉलिज्म किससे होता है? लिवर से. एलिमिनेशन किससे होता है? किडनी से होता है. अभी किडनी फेलियर ही है तो जो मेटाबोलाइट होता है दैट इज 3 hydroxy vecuronium, which is the metabolite. This metabolite is itself having the neuromuscular blocking action and therefore इसका action prolong हो जाएगा, effect prolong हो जाएगा अगर kidney failure है, and that is what is basically happening here because of the accumulation of the active 3 hydroxy metabolite. Okay, all right, next question. A 22-year-old male complains of lower back pain and morning stiffness for the past 2 years. Young male है, ठीक है, young patient है आपके पास. Additionally, he has been experiencing bilateral heel pain for the last 6 months. ये क्या होता है बेटा heel pain? We are talking about enthesitis here. So enthesitis is a hallmark for ankylosing spondylitis. So basically, Achilles tendon आपका involved हो गया at the site of insertion at the calcaneum or even the plantar fascia. That is what is giving rise to the heel pain. So back pain, which is there along with the morning stiffness, and spondyloarthropathies की बात हो रही है. Characteristic feature enthesitis. What is the diagnosis here? It is ankylosing spondylitis. Okay. All right, next question. A 6-year-old boy falls on his outstretched hand. So what is this? Basically telling you about the supracondylar fracture, most likely. The elbow is swollen. Pulses are not palpable. Very important. मतलब अब क्या हो रहा है? Forearm is appearing pale and tense. Passive extension of the fingers is causing severe pain. What is the next best step? क्या हो चुका है इस patient के अंदर? There was supracondylar fracture. Supracondylar fracture हुआ. इंजरी किसकी हो सकती है? ब्रेकियल आर्टरी की इंजरी हो सकती है. दैट हैज लेड टू व्हाट? इट्स अ कंपार्टमेंट सिंड्रोम. नाउ इस पेशेंट को क्या हो चुका है? कंपार्टमेंट सिंड्रोम. अब कंपार्टमेंट सिंड्रोम में क्या करते हैं? इमीडिएट मैनेजमेंट हैज टू बी fasciotomy. देयर इज नो टाइम टू वेट. यू हैव टू रिलीज द प्रेशर. Otherwise, if you are not correcting it, if it is not done, it can lead to volcanic ischemic contracture of the muscles because of the fibrosis that is going to ensue. So currently we are at the stage of compartment syndrome, and that too, pulselessness क्या होता है बेटा? Late feature होता है. Pulselessness जो है वो late feature होता है, याद रखना. मतलब already we are way advanced into the compartment syndrome. The best thing you have to do is immediate fasciotomy. कोई MRI नहीं, कोई CT angio कुछ नहीं, immediately आपको fasciotomy करनी है पेशेंट की. ठीक है? Okay, next. A 35-year-old male presents with dull groin pain. 35-year-old male है, dull groin pain है, which is aggravated by weight bearing. Okay, history of prolonged steroid use, very very important. So prolonged steroid use के साथ, if you get the X-ray of the hip, which is characteristically showing what? It is showing subchondral necrosis. दिख रहा है आपको subchondral necrosis, and here you can see the characteristic sublucent shadows मिल रही है आपको. This is your crescent sign that you're looking at. Okay, this is the crescent sign because of the subchondral necrosis. What is it they are talking about? Basically, you're talking about the avascular necrosis of the femur. Steroids are characteristically known to cause this kind of effect. So this is your, whenever you have steroid presentation with an X-ray of the hip, you're generally talking about AVN. Okay, that is what you should be knowing. Okay, all right. Next question. Which of the following is not a functional component of the nerve that is marked in the image? So it is not very clear. Generally, पर समझ में आ रहा है अगर neck में कोई nerve mark करने की कोशिश कर रहा है, तो basically we are talking about the vagus nerve. ठीक है? तो vagus nerve का component कौन सा नहीं है पूछा है. Now, does vagus nerve supply any skeletal muscle? No. Larynx और pharynx की muscle को supply करते हैं, but skeletal muscle को supply करते हैं. So will they be having general somatic efferent? No, they will not be having general somatic efferent. So what is not a functional component? This is what is not a functional component of vagus nerve. Which of the following muscle are involved in the movement shown in the image? So what is happening here? There is lateral flexion. ठीक है, patient is having lateral flexion कर रहा है patient. So कौन सी muscle responsible होती है? Ipsilateral, external oblique, and internal oblique. These are what are responsible for the lateral flexion of the patient. ठीक है बेटा? Okay. A female patient presents with loss of sensation over lateral 3.5 fingers on the palmar aspect. Lateral 3.5 fingers से sensation चला गया, मतलब ये 3 fingers चली गई आपकी. Lateral 3.5 are gone. So that means we are talking about which nerve that is involved. We are talking about the median nerve that is involved. Median nerve कौन सी टनल में होती है? गायन्स कैनाल में होती है कि कार्पल टनल में होती है? कार्पल टनल. गायन्स कैनाल में कौन सी नर्व होती है? अल्नर नर्व होती है. अब कौन सा टेस्ट करते हैं बेटा? We do the Darkins test here. तो हम क्या करते हैं? We press the median nerve in the carpal tunnel. Carpal tunnel में दबा के रखते हैं उसको 30 seconds तक. That produces the symptoms which is known as your tingling, numbness, paresthesia produce होते हैं. That is what is your characteristic Darkins test. ठीक है? So this is what is the correct pair that is supposed to be answered for this question. Next. A 60-year-old male is presenting with progressive hoarseness of the voice. Laryngoscopy video is provided. क्या दिख रहा है laryngoscopy video में? आपकी राइट साइड की वोकल कॉर्ड तो मूव कर रही है, लेफ्ट साइड की जो वोकल कॉर्ड है वो मूव नहीं कर रही है. इट्स नॉट मूविंग. सो लेफ्ट साइडेड वोकल कॉर्ड पाल्सी है. लेफ्ट वोकल कॉर्ड पाल्सी आपको दिख रही है इसके अंदर. ओके. ट्रांसथोरैसिक echocardiography reveals an enlarged cardiac chamber causing this clinical finding. Which of the following cardiac chambers is most likely dilated? तो हम किसकी बात कर रहे हैं बेटा? We are basically talking about what? We are talking about the Ortner syndrome. और कार्डियोवोकल सिंड्रोम भी बोलते हैं इसको बेटा, इट्स आल्सो कॉल्ड एज द कार्डियोवोकल सिंड्रोम। बेसिकली हो क्या रहा है, आपकी लेफ्ट आर्लिन जो होती है, लेफ्ट साइड रिकरेंट एंजियल नर्व, वो किसके पास से निकलती है, लेफ्ट एट्रियम के पास से निकलती है। तो लेफ्ट एट्रियम जो है, अगर उसकी साइज बड़ी तो इट कैन कॉज कंप्रेशन ऑफ द लेफ्ट रिकरेंट एंजियल नर्व एंड दैट कैन प्रोड्यूस द hoarseness of voice. So this is your characteristic Ortner syndrome. The answer is going to be left atrium. ठीक है, आया समझ में? Okay, next question. Now, this is an interesting question. So, you have a 10-year-old boy who's brought to the outpatient clinic because of the involuntary movements of the right hand as shown in the accompanying video. ठीक है, तो किस तरह के dance-like movements दिख रहे हैं आपको पेशेंट के? His mother reports that the movement began gradually over the past week and interfere with the activities such as writing and holding objects. Okay. अब आया आपका main clue. Episode of rheumatic fever 2 months ago. That is what is definitely going to confirm the diagnosis of Sydenham chorea. ठीक है. एक इन्फेक्शियस एपिसोड पहले आया बेसिकली, तो क्या हुआ, पेशेंट को एंटीबॉडीज बनी किसके अगेंस्ट में, ग्रुप ए बीटा, ग्रुप बी हेमोलिटिक स्ट्रेप्टोकोकाई, GABHS के अगेंस्ट में एंटीबॉडीज बनी। अब इन एंटीबॉडीज ने क्रॉस रिएक्ट किया, क्रॉस रिएक्ट करके क्या हो गया, नाउ देयर इज अ प्रॉब्लम व्हिच इज हैपनिंग। कौन से न्यूरॉन्स के साथ क्रॉस रिएक्ट किया, बेसल गैंग्लिया, वेयर striatum, caudate nucleus plus putamen, and therefore all the problems related to that is happening. So that is what is leading to the coriform movements, component of acute rheumatic fever, major criteria. So what constitutes the basal ganglia here? It is the caudate, which structures, caudate nucleus and putamen are basically affected. Diagnosis, Sydenham's chorea. These are the coriform movements which are happening in this patient. Next. Muscle derivatives of the structure 1 are first pharyngeal arch. Muscle derivatives क्या होते हैं बेटा, muscles of mastication, mylohyoid, tensor villi palatini, tensor tympani. This is a standard question. ज़्यादा discuss करने का कुछ होता नहीं है इसमें। तो first arch you have the muscles of mastication supplied by, which is the nerve of the first arch. It's the mandibular division of the trigeminal nerve. So muscles of mastication, mylohyoid, anterior digastric, टेंसर टिम्पेनाई एंड टेंसर विला पैलेटाई। सेकंड आर्च से क्या बन रहा है आपका, सेकंड आर्च से बन रहा है आपके मसल्स ऑफ फेशियल एक्सप्रेशन, इंपॉर्टेंट नर्व फेशियल नर्व से सप्लाई हो रहे हैं। अदर देन दैट स्टेपेडियस, स्टाइलोहायोइड एज वेल एज पोस्टीरियर डाइगैस्ट्रिक। थर्ड आर्च कौन सी नर्व है आपकी, ग्लॉसोफेरेंजियल नर्व, मसल कौन सी है, स्टाइलोफेरेंजिस। फोर्थ आर्च योर सुपीरियर लैरिंजियल नर्व, क्लिक्कोथायरॉइड, वेरी इंपॉर्टेंट, लेवेटर विला पैलेटाई एंड द फेरेंजियल constrictors. Sixth arch nerve is recurrent laryngeal nerve, which is the most important thing you need to remember. Except cricothyroid, all the intrinsic muscles. Cricothyroid is from the fourth arch. ठीक है? Okay. Next question. Straightforward question once again. A 32-year-old male presents with recurrent spontaneous pneumothoraxis and a history of sigmoid colon perforation. मतलब लंग इन्वॉल्व हो गया आपका, न्यूमोथोरैक्स है आपको, साथ में बाउल भी इन्वॉल्व हो रही है, एंड फिजिकल एग्जामिनेशन रिवील्स थिन ट्रांसल्यूसेंट स्किन विद प्रोमिनेंट वीनस पैटर्न, मतलब ब्लड वेसल्स भी इन्वॉल्व हो रही है, सो ब्लड वेसल्स आर आल्सो इन्वॉल्व। Genetic testing reveals a pathogenic mutation in COL3A1 gene, basically type 3 collagen का है, so this is vascular form of Ehlers-Danlos that we are dealing with. So which type of collagen is functionally impaired? It's the type 3 collagen that is functionally impaired in the vascular type of Ehlers-Danlos syndrome. Okay. So ये आपको टेबल बेटा याद होनी चाहिए. In type 1 collagen, we have the involvement of bone, skin and tendon. What is the disease in type 1? It's osteogenesis imperfecta. Type 2, we talk about the cartilage and the vitreous bodies are the major sites, important syndrome, Stickler syndrome. Type 3, we talk about the blood vessels, the skin and the hollow organs, which is the one, it's the vascular EDS, जैसा कि हमारे क्वेश्चन में डिस्क्राइब था. Type 4, basement membrane, most importantly कौन सा, Alport syndrome and good posture. दो important होते हैं type 4 collagen से, okay? That is what you should be knowing. Question number 34. A 2-day-old newborn presents with 2 दिन का बच्चा है newborn with poor feeding and tachypnea. Okay. On auscultation, there is a continuous murmur heard best at the left infraclavicular area. Continuous machinery murmur left infraclavicular. क्या है diagnosis? Patent ductus arteriosus, connection aortic arch and the pulmonary artery. The pediatrician suspects a persistent fetal cardiac connection. Absolutely true. At which location is this structure most commonly found? It is found distant to the left subclavian artery between the aortic arch and the pulmonary artery. ठीक है? So this is what is the answer for this question. Patent ductus arteriosus has बच्चे को. Okay? All right. Next question. A patient presents diagnosed with sciatica diagnosed है उसको and is experiencing tenderness in the hamstrings. Has a hybrid muscle that is spared. Okay. So basically hamstring को कौन सा part supply करता है? Tibial part of the sciatic nerve. So tibial part of sciatic nerve is supplying the hamstring. This is one thing you should be knowing. Which nerve supplies this hybrid muscle? कौन सी hybrid की बात कर रहे हैं बेटा? हम बात कर रहे हैं adductor magnus की. इसकी दो सप्लाई होती है. It is supplied by the obturator plus the tibial part of the sciatic nerve. So basically obturator nerve जो है वो supply कर रही है इस hybrid muscle को. So your answer is the obturator nerve. Okay. All right. Next question. The image shows the characteristic seeds of a highly toxic plant that were traditionally used by Indian goldsmiths for weighing gold and silver. Okay, all right. So active principle of the seeds. कौन से seeds हैं बेटा? These are your rati seeds. Rati seeds बोलते हैं इनको Abrus precatorius. These are the Abrus precatorius. अब क्या पूछा है? क्वेश्चन क्या पूछ रहा है? Principle, active principle of these seeds include all of the following except. नाम से ही समझ में आ रहा है बेटा. एब्रिन और एब्राइन दोनों ही होंगे ऑब्वियसली. हीमोग्लूटिनिन भी होता है. रिसिन किस में मिलता है? इट इज सीन इन केसेस ऑफ रिसिनस कम्युनिस, दैट इज योर कैस्टर प्लांट. ठीक है, उसके अंदर आपको ये वो मिलता है. तो ऑब्वियसली क्या पूछ रहा है? एक्सेप्ट पूछा है. सो द आंसर इज गोइंग टू बी ऑप्शन नंबर डी. ठीक है, ओके. The video shows a forensic screening test being performed on a suspected stain which has been removed from a knife, recovered from a knife. Which of the following statements regarding the test shown is most accurate? क्या accurate है? तो test क्या use हो रहा है बेटा? This is your Castle-Mayer's test. Okay, this is your Castle-Mayer's test. Phenolphthalein test भी होता है बेटा. तो क्या टेस्ट करता है? बेसिकली इट इज टेस्टिंग द peroxidase activity of the hemoglobin. Straightforward question. You should be able to identify this test. Okay. All right. Next. A food safety inspector discovers that a fruit vendor is applying substance shown in the image to the fruits to make them appear fresh and bright before sale. ये real life instances भी है, ध्यान रखिएगा. तो क्या दिख रहा है आपको? दिस इज अ रैट पॉइजन. सो रोडेंटिसाइड है. इट्स अ रोडेंटिसाइड. ओके. A 28-year-old woman consumes these fruits and presents to the emergency department 8 hours later. Despite aggressive resuscitative measures, she develops refractive ventricular tachycardia and dies within the 18-hour window. The most likely immediate cause of death. अब इसमें क्या मिलता है बेटा आपको? येलो फॉस्फोरस होता है. दिस इज व्हाट यू ऑलरेडी नो. इट कंटेन्स येलो फॉस्फोरस. अब आप बोलोगे सर एक्यूट लिवर फेलियर होता है? होता है, बिल्कुल होता है. सो दिस इज ट्रू. बट टाइम विंडो क्या पूछी है उसने? 18. दिस इज जनरली सीन 48 to 72 आवर्स की टाइम विंडो होती है जब ये मैनिफेस्ट करता है. Immediately अगर ये हो रहा है, it is because of the cardiac dysrhythmias which is secondary to the electrolyte abnormalities which include hypocalcemia and hyperkalemia. तो बेटा ध्यान से पढ़ना है. कितना दिया है उसने टाइम फ्रेम? 18 घंटे के अंदर. इतनी जल्दी acute liver failure आपको नहीं मिलेगा. This is basically because of the cardiac dysrhythmias because of hypocalcemia and hyperkalemia. ठीक है, okay. Next question. So we have a body of 28-year-old man who allegedly died. So 28-year-old man है who allegedly died due to hanging is brought for medico-legal autopsy. तो आपको अगर hanging के patient को देखना है, autopsy करनी है, तो main important region is going to be the neck region. So what is the skin incision most appropriate? So for hanging, the most appropriate is your modified Y incision that is given. ठीक है. तो हम स्टैंडर्ड जो यूज करते हैं, हम आई शेप इंसिजन यूज करते हैं, बट फॉर हैंगिंग कैरेक्टरिस्टिकली वी यूज द मॉडिफाइड वाई. It can extend right up till the mastoid, come to the center in between, and then it is extended further downwards across the stump, right? So this is what you should be knowing. It's the modified Y incision. The image, next question. The image depicts a homicidal method of mechanical asphyxia. Which of the following PM findings is most likely to be seen? क्या दिख रहा है बेटा? The person is putting pressure on the chest. तो chest के ऊपर बैठा है और मुंह दबाया हुआ है, नाक दबाई हुई है. So what is happening? There is a combination of traumatic asphyxia plus he is also smothering the patient. So traumatic asphyxia and smothering. What is this called as? This is your working which is happening. So traumatic asphyxia, smothering along with cyanosis and petechia. This is what you're going to find in this patient. ठीक है? So this is what you should be know. Next, a pedestrian in a road traffic accident is found to have a large area of skin torn off from the leg with the skin detached from the underlying tissue. The margins are irregular and bruised. Which type of laceration is most consistent? तो क्या हुआ है इसमें? रोड ट्रैफिक एक्सीडेंट हुआ, टेंजेंशियल प्रेशर लगा तो स्किन भी एवल्स हो गई है पूरी. सो दिस इज बेसिकली एवल्शन काइंड ऑफ लैसरेशन. दिस इज व्हाट इज बीइंग आस्क्ड इन दिस क्वेश्चन. ठीक है, ओके, दिस इज व्हाट इज वेरी क्लियर. Next question. A pregnant woman in the eighth month of gestation is intentionally assaulted. Intentionally उसे assault किया गया, resulting in the death of a viable quick fetus in the utero. ठीक है, in utero death हुई है. The child was never delivered alive. Under which provision of Bharatiya Nyaya Sanhita is the offender most appropriately charged? क्या बेसिक असॉल्ट वाज फॉर किलिंग द चाइल्ड? नो, इट वाज मेंट फॉर किलिंग द फीमेल. ठीक है, तो इंटेंशनली असॉल्ट किया गया है उसको, बट बिकॉज ऑफ द असॉल्ट द बेबी डाइड. दिस इज व्हाट इज सेक्शन 92. अगर आपने कुछ अगर ऐसा होता है कि फीमेल को कुछ खिलाया गया टू किल द चाइल्ड, दैट वाज द सेक्शन 91. ये क्या किया गया, इसमें असॉल्ट किया गया. सो कल्पेबल होमिसाइड आया उस पे ऊपर, एक्चुअली वाज फॉर द फीमेल, but as a resultant measure the child was suffering, right? So this is what it is. When you do an intentional act to prevent a child from being born alive or cause it to die after birth, this is 91. 92 क्या होता है, डेथ ऑफ अ क्विक अनबॉर्न. क्विक मतलब क्विकनिंग फील हो गई थी फीमेल को, मूवमेंट्स फील हो चुके थे, by act amounting to culpable homicide. Actually culpable homicide female पे था, but that led to the death of the child. That is 92. 100 gives the definition of culpable homicide, and 103 one segment or part 1 is the punishment for murder. Okay, all right, next. The question was asking that there is a partially decomposed body that is recovered. Male body is recovered. Okay. Forensic examination reveals the following. क्या reveal कर रहा है forensic examination? Medial end of the clavicle shows recent fusion. पूछना क्या चाह रहा है? Age range पूछना चाह रहा है. तो medial end of the clavicle shows fusion roughly in the range when the patient is 16 to 18 years. Iliac crest epiphysis is unfused. Okay. All right. तो basically 17 के आसपास फ्यूज होना शुरू होता है. Third बोलो. So this is 17 years. This is also roughly in that range. Sternal end of the fourth rib does not show fusion. ये 20 के beyond fusion show करता है. So this is in the range of 16 to 18. It is not 18 to 20 because there is no fusion that has happened on the sternal end. So this also gets ruled out. But 14 to 16 नहीं हो सकता क्योंकि roughly 17 के आसपास third molars appear होना शुरू होते हैं. So therefore the answer is going to be 16 to 18. ठीक है? All right. Next question. A 55-year-old man with history of hypothyroidism, ठीक है, presented to the ENT OPD with complaints of hearing loss. तो पहला feature हो गया, hearing loss मिल रहा है, plus 1 year, which unilateral hearing loss, so unilateral hearing loss, which precedes dizziness. Dizziness भी था, vertigo हो गया साथ में, which is accompanied by stomach pain, nausea, vomiting. Patient also complains of ringing sensation in ear and sense of fullness. So tinnitus भी है साथ में, plus there is oral fullness. Plus there is a background history of hypothyroidism. ठीक है, अपने पीटीए किया, पीटीए में क्या दिख रहा है कि लोअर फ्रीक्वेंसीज पे आपको हियरिंग लॉस है, which is fluctuating kind of hearing loss, and it is improving in the higher frequencies. Higher frequencies में improve हो रहा है. What is this? This is characteristically the presentation of Meniere's disease, or what we call as the endolymphatic hydrops. So basically, this is the presentation that you're having. Hypothyroidism basically is one of the important risk factors that is seen or been talked about in cases of patients with Meniere's disease. So fluid abnormalities are caused because of hypothyroidism. ठीक है बेटा? Okay, so this is what you should be knowing. Next question. An X-ray of 1-year-old child was done to study the sphenoid sinus. Sphenoid sinus को study करने के लिए X-ray किया. Which of the statements regarding the features observed in the X-ray is correct? Okay, correct पूछा है. Sphenoid sinus is going to show the signs of development, not true. Sphenoid sinus show नहीं करेगा, क्यों? क्योंकि roughly 3 to 4 years or even 4 to 5 years के आसपास sphenoid sinus के कुछ signs मिलने लगते हैं. Pneumatization शुरू हो जाता है 6 months to 1 year पे, but आपको characteristically दिखेगा नहीं. Both the we are not correct. It is not visible on X-ray. एक साल पे sphenoid sinus नहीं दिखते हैं. क्या दिख सकते हैं? Maxillary दिख सकता है, ethmoid दिख सकता है. ये दो main sinuses आपको दिख सकते हैं. ठीक है? These are seen at birth. Next question. Which of the following is not true? Not true पूछ रहा है regarding the lymphatic drainage of larynx. सुप्राग्लॉटिक लैरिंग्स ड्रेन्स इनटू लोअर डीप सर्वाइकल, लोअर डीप में नहीं है बेटा, इट गोज टू अपर, ठीक है, अपर डीप सर्वाइकल में ड्रेन करता है, तो दिस इज नॉट ट्रू। वोकल कॉर्ड द स्कैंटी लिम्फेटिक्स एब्सोल्युटली ट्रू, इसलिए ग्लॉटिक जो होता है उसका बेस्ट प्रोग्नोसिस होता है। इंफ्राग्लॉटिक लैरिंग्स ड्रेन्स इनटू प्रीलैरिंजियल एंड प्रीट्रेकियल, ट्रू स्टेटमेंट। सुप्राग्लॉटिक हैज द मैक्सिमम लिम्फेटिक ड्रेनेज, आल्सो ट्रू, सो व्हिच इज नॉट ट्रू, ऑप्शन ए इज नॉट ट्रू, दैट इट ड्रेन्स टू लोअर डीप, इट ड्रेन्स टू अपर डीप, ठीक है, तो ए आपका इसमें आंसर होगा। नेक्स्ट, which of the following is not an indication for the use of instrument depicted in the video? क्या इंस्ट्रूमेंट दिख रहा है बेटा? बेसिकली ट्रेकियोस्टोमी ट्यूब दिख रही है, ट्रेकियोस्टोमी ट्यूब है, ठीक है, ट्रेकियोस्टोमी आपका प्रोसीजर हो रहा है इसमें, ट्रेकियोस्टोमी ट्यूब। अब इसका इंडिकेशन नहीं है प्रोलॉन्ग मैकेनिकल वेंटिलेशन, एब्सोल्युटली, आप जब भी प्रोलॉन्ग करना होता है तो कभी भी एंडोट्रेकियल ट्यूब प्रेफर की जाती है क्या? नहीं की जाती। सो व्हाट डू वी यूज अ ट्रेकियोस्टोमी, ठीक है, ट्रेकियोस्टोमी प्रेफर करते हैं। एयरवे टॉयलेटिंग, एब्सोल्युटली, सिक्रीशंस आपको क्लीन करना है तो आप ट्रेकियोस्टोमी से बेटर क्लीन कर सकते हो, दैट इज व्हाट इज पॉसिबल बिकॉज ऑफ ट्रेकियोस्टोमी। अपर एयरवे को एग्जामिन करते हो क्या बेटा? नो, दिस इज नॉट द फंक्शन और इंडिकेशन फॉर द यूज ऑफ ट्रेकियोस्टोमी। अपर एयरवे को एग्जामिन करने के लिए आप उसको ट्रेकियोस्टोमी थोड़ा ना कर दोगे पेशेंट में। एक्यूट नेसोफेरिंजियल ऑब्स्ट्रक्शन है, एब्सोल्युटली, अगर आप एक्सेस ही नहीं ले पाओगे, नेसोफेरिंज का पूरा रूट ऑब्स्ट्रक्टेड है, तो आपको क्या ट्रेकियोस्टोमी करनी पड़ सकती है। सो द आंसर इज गोइंग टू बी अपर एयरवे एग्जामिनेशन, ठीक है, ओके। Next, a 52-year-old fisherman with a history of prolonged outdoor sun exposure presents with the redness and foreign body sensation in his right eye. The video shows the surgical excision of the ocular lesion during the treatment. कहाँ पर आ रहा है बेटा? It is now coming on to the cornea. Cornea के ऊपर आ रहा है lesion. What is the most likely diagnosis? So, outdoor UV exposure, ठीक है, कमिंग ऑन टू दी कॉर्निया, कॉर्निया पे आ रहा है। ऑल ऑफ दीज आर फीचर्स टुवर्ड्स द डायग्नोसिस ऑफ टेरिजियम। अगर पिंगिकुला होता तो दिस वाज रिस्ट्रिक्टेड टू द लिम्बस, ये लिम्बस तक रिस्ट्रिक्ट रहता है, इट डज नॉट अप्रोच द कॉर्निया, कॉर्निया पे नहीं आता है पिंगिकुला, सो देयरफॉर द आंसर हियर इज गोइंग टू बी टेरिजियम। दीज आर द हॉलमार्क फीचर्स। यूवी एक्सपोजर के साथ होता है पेशेंट को फॉरेन बॉडी सेंसेशन, रेडनेस होती है एंड इट एंक्रोचेस ऑन टू द कॉर्निया, ठीक है, सो दैट इज टेरिजियम। ओके, नेक्स्ट क्वेश्चन। A 59-year-old man presents with the sudden onset of flashes of light and multiple floaters in his eye for 3 days. तो जब भी flashes of floaters की बात होती है तो एक चीज तो हमको पता है क्या हो चुका है, पेशेंट को posterior vitreous detachment हो चुका है। Flashes happen because of posterior vitreous detachment, एक तो पहली चीज ये हो गई। The video shows the ocular findings seen on examination. तो क्या दिख रहा है बेटा? If you see that there is a tobacco dust, Schaffer's sign बोलते हैं इसको, this is called as the Schaffer's sign, right? What we see like tobacco dust. क्यों दिख रही है tobacco dust patient के अंदर? Because of the pigment cells. So pigment cells from where retinal pigment epithelium are now leaking into the anterior side, vitreous में आ रहे हैं because of the break. तो retina का break हुआ, retina का एक break हुआ, there was a break in the retina, and that is what led to the pigment cells coming forward. Okay, so this is what is basically leading to the sign. So this patient basically has a retinal break. ठीक है, okay. Next question. A patient develops pterygium. Okay, Dhanush, hi. Okay, a patient develops an opacity after superficial corneal injury. The ophthalmologist explains that the scar is permanent because the damaged layer has no regenerative capacity. Which is the layer involved? Now you should be knowing this. इस पे कोई discussion की जरूरत नहीं. It's the Bowman's layer or the Bowman's membrane which has no regenerative capacity and therefore the scar is going to be permanent. तो ये आपको directly पता होना चाहिए. A 7-month-old infant, 7 month का बच्चा है, brought by his mother with the complaints of excessive watering from the left eye, difficulty opening the left eye in bright light. What is this beta? This is photophobia. Patient को photophobia भी है, साथ में watering भी हो रही है. Based on the video, what is the most likely? क्या दिख रहा है इस आंख में? What can you see here? There is corneal haziness, or there is corneal edema basically. So corneal edema plus photophobia plus watering from the left eye, characteristic combination for the diagnosis of congenital glaucoma. ठीक है बेटा, आपको bluish सी eye दिख रही है, this is characteristically congenital glaucoma. ठीक है, okay. A 58-year-old man presents with progressive diminution of distant vision but reports 58-year-old man. Okay, धीरे धीरे विजन कम हो रहा है. but now reports that he's able to read near objects without using his reading glasses based on the ocular examination provided. What can you see here? So basically you can see that ये कौन सा shift मिलता है इसको? This is called as myopic shift. ये क्यों मिल रहा है myopic shift? It is because of the nuclear sclerosis, या हम बोलते हैं इसको न्यूक्लियर कैटरैक्ट. न्यूक्लियर कैटरैक्ट हुआ तो क्या हुआ? लेंस वहां पर हार्डन हुआ, न्यूक्लियस का जो एरिया वहां पे हार्डन हुआ. न्यूक्लियस इज द एरिया वेयर ऑल द सेल्स, रीजनरेटिव सेल्स बाहर कॉर्टेक्स की तरफ आते हैं, बीच में सारे पुराने फाइबर्स होते हैं. देयर इज हार्डनिंग व्हिच यू सी, न्यूक्लियर स्क्लेरोसिस, एंड दैट इज व्हाट इज टेम्परली इंक्रीजिंग द रिफ्रैक्टिव इंडेक्स ऑफ द आई. This is what is called as the this is called as the index myopia. Okay, so this is what is your answer here. Let's quickly discuss the other variants. So most commonly it is the axial myopia, जिसमें anterior-posterior lens of the eyeball is increased. This is the most common type. At times there can be curvature myopia because of the increase in the curvature of the cornea and lens. So two refractive surfaces, cornea majority, 2/3 of the power of the eye, 1/3 remaining is with the lens. So that is what is seen in cases of keratoconus. Curvature myopia because of the keratoconus. Index myopia because of the nuclear cataract that we see here. It is because of the refractive index increase in the lens of the eye, that is nuclear sclerosis. And positional myopia is because of the anterior displacement of the lens. So lens position abnormality. ठीक है? Next question. ये तो बड़ा सिंपल स्ट्रेट फॉरवर्ड क्वेश्चन है, इसमें कुछ था ही नहीं. इट्स समथिंग दैट यू हैव बीन रीडिंग सिंस अ लॉन्ग टाइम. क्या दिख रहा है आपको? यू कैन कैरेक्टरिस्टिकली सी दैट द पेशेंट हैज व्हाट? बिग इतने बड़े बड़े क्या है पेशेंट को? EDH दिख रहा है. EDH है एक्स्ट्रा ड्यूरल लेंटिकुलर शेप ओपेसिटीज दिख रही है. यू कैन सी द लेंस शेप ओपेसिटीज दैट यू कैन सी. हाइपरडेंस ब्लीड हो गया है पेशेंट को. कौन सी आर्टरी इन्वॉल्व होती है? मिडिल मेनिंजियल आर्टरी. ठीक है. SDH में ब्रिजिंग वेन इन्वॉल्व. कैसा मिलता है? क्रिसेंट शेप होता है. ठीक है, ये हमको पता है. So it's a branch of the middle meningeal artery, and this is what is your answer, option number C. Next question. Which of the following statements regarding chest radiography are correct? क्या सही है? Approximately 75 ml of pleural fluid is sufficient to blunt the posterior costophrenic angle on the lateral chest radiograph. That's a true statement. 75 ml lateral, उसमें इतनी blunting आपकी हो जाएगी 75 ml पे. The right minor horizontal fissure is the pulmonary fissure most commonly visible on the frontal. Frontal पे एक ही fissure visible होता है. That is your right minor or the horizontal fissure. That is true. Compression fractures of the thoracic vertebra most commonly begin with depression of the superior end plate. That is true. Superior end plate depress होती है. These are the osteoporotic fractures which are generally seen, pathological fractures. So this is a true statement. Degenerative disc disease characteristic result in widening of the intervertebral disc spaces. Not true. It is a narrowing of the disc spaces. So narrowing होती है बेटा. ठीक है, not true. So this is not true. Curly B lines are commonly seen with interstitial pulmonary edema. That is true because of the fissural thickening due to pleural fluid. Correct. Thickening of pulmonary fissure without other signs of fluid overload is because of the fibrosis. Definitely it is occurring because of the fibrosis. तो 4 को छोड़कर बाकी सारे सही हैं. So 1, 2, 3, 5 and 6. Okay, so option number B is correct. Okay. So those were the share of questions from the surgery and the allied concepts that were supposed to be discussed. That is all from my side, beta. But we'll be meeting again for the discussion on grant test, for the second grant test on 17th. सब 16 को आपका टेस्ट लाइव हो जाएगा. Do attempt the test. Discussion नहीं भी attempt कर पाते हो तो it is fine. Just stay calm. जितना भी टाइम बचा है मैक्सिमम यूज करने की कोशिश करो. दिमाग में बहुत ज्यादा चीजें लाने की जरूरत नहीं है कि क्या छूट गया है, क्या नहीं हुआ है. रोज का टारगेट सेट करो, जल्दी जल्दी रिवाइज करो. एक आध घंटा कोशिश करो कि क्वेश्चन प्रैक्टिस भी करनी है. डोंट कंप्लीटली गो इनटू द थ्योरी. सॉल्व सम पार्ट ऑफ क्वेश्चंस एवरी डे. 1 घंटे 1.5 घंटे के आसपास क्वेश्चन सॉल्व करो. कोशिश करो 12-13 घंटे की आपकी थ्योरी रीडिंग रखो. भरोसा रखो. That is the most important thing. Have faith on yourself. Have faith on the God that you worship. Everything is going to be fine in the end. ठीक है बेटा? So that was all from my side, and thank you so much.
Okay, hi. Hi, dear students. How are you? How was your exam? I hope maximum of you have given your exam. And let me just connect with the YouTube also. And let me know how was your experience with the exam? How was your OBG paper? How did you answer? Please do let me know. Yes, one more thing is, I know you have been stressed from 6 o'clock, medicine, surgery, major subjects you have been doing, but relax. OBG paper was easy as far as I think, and what you have read, it was easy, and you have cracked it also well. Don't worry. I have seen the results, scores, everything. So don't worry, you are in a good place and you will crack your exams well. Don't take tension first of all. And first of all, relax for 2 minutes, have some water. Let us begin with our OBG paper discussion. We hardly had some 20 questions in OBG and they all were easy. 5 questions I agree were difficult of the 20, and rest 15 I'm sure maximum of you have answered in your exam also. From the graph that I've received also, maximum of you have answered in that. Okay, so now let us start with the OBG paper discussion. Are you okay? You're fine? You want some rest? Yes, please let me know you want some break for 1 or 2 minutes. Then we'll start, or we'll just start away. I'm good to start. Let us start with the first question if you're all okay. Okay, fine, students. Then we'll start away for the first question. Okay, so let us begin with the first question. This is our question. A 37-year-old primary gravida at 38 weeks of gestation. Is the audio, video, everything audible? Can you see the slide on the PPT? Yes or no? Please let me know. I think the slide is not moving. Is it moving? And reshare again. Okay, so I think now the slides are moving. So this is your first question. Okay, a 37-year-old primary gravida at 38 weeks of gestation has persistent shoulder presentation. Okay, so shoulder is the presenting part. The following procedure is attempted, but it was unsuccessful. What is the most appropriate next step in the management? First of all, here you should know. Yes, yes, you can message in the group, no problem, in the WhatsApp chats. Okay, so now you can tell. First, you should know it is shoulder presentation. Shoulder means what is the presenting part? Acromion. So in the video, though it is shown breech, but even for shoulder or breech, the procedure that is done to rotate is called as, yes, it is external cephalic version. Yes, so they are trying to do external cephalic version externally. That means from the abdomen, cephalic version. That means trying to get the head down. Okay, so this is what they are trying to do. In the video also it is very clearly seen. So they did external cephalic version. It failed. So what do you want to do next is the question. Correct? No. So what is the most appropriate next step in the management? Induction of labor. If you could do induction of labor in the first go itself, why did you even attempt external cephalic version? Isn't it? So is it a waste of time? Then you're doing waste of energy, waste of the doctor resources, everything, isn't it? So shoulder presentation cannot deliver vaginally, isn't it? So when there is a shoulder, that means head or buttocks are not there, it cannot come out at all. So what maximum will cause? Hand prolapse will happen or cord prolapse will happen, isn't it? So it cannot have a vaginal delivery. So you cannot do induction of labor. It is very direct question. So when it cannot have a vaginal delivery, what best you can do is a elective cesarean section, isn't it? So the correct answer here would be B. So that is the elective cesarean section. Internal podalic version. Yes, tell me, where do you do internal podalic version? Yes, where do you do internal podalic version? Yes, it is done in second twin. Okay, and it is podalic, trying to get the buttocks down. So let us say it is shoulder presentation in the second twin. So in exam they had given you second twin was shoulder presentation. What is the procedure that you want to do? That is the only place where you can do internal podalic version. That means go inside, do PV, hold the fetus of the fetus limbs, lower limbs, legs, and try to get the buttocks down and deliver the buttocks first. So that becomes internal podalic version. Remember, this is external cephalic version. The head is coming down. There it is, the buttocks are coming down. That means it is internal podalic version. The only indication for internal podalic version is second twin. Okay, for the second twin when it is in shoulder presentation or transverse line. Okay. Vacuum assisted vaginal delivery, again there is no chance of vaginal delivery at all. Coming to the vacuum on forceps, the only drawback of vacuum over forceps, not the only, one of the major drawback for vacuum over forceps is forceps can be applied for breech also, for head also, but vacuum can be applied only in vertex presentation. It should be only vertex, whereas in face, buttocks, anything we can apply forceps at least, but not in shoulder, definitely none of them, because shoulder cannot have a vaginal delivery at all, isn't it? So this I'm sure all of you have answered. Going ahead with the next question. A woman presents with uterine prolapse and is managed conservatively using a vaginal device. So what is this device? So they're not asking any direct questions here. So we have asked you at least 3-4 questions so that you can answer. Even if the same topic, some 4 questions they give also, you'll be able to answer. Okay. What is this device? It is a vaginal pessary, ring pessaries. Yes. So the instrument shown in the image is used for her treatment. For the prolapse, they are using a pessary. Maybe she is old age, she is not fit for surgery, or she doesn't want surgery, whatever is the reason. Which of the following statements regarding the instrument is false? Okay, what is false we have to tell. So when you are inserting a pessary, that means you should know what are the things that you should advise the patient. That is why this question is asked. Correct? No. So now let us see. Again, all these are clinical topics and clinical implications only. So when you are inserting a pessary, will you advise your patient needs replacement every 3 months? Yes or no? Yes, you will advise your patient. It requires replacement every 3 years. It should be kept sterile. We should keep it in sterilium for at least half an hour and then return it back to its position every 3 months once. Then, may cause discomfort and dyspareunia. Yes, it might cause discomfort and dyspareunia. That is the most common indication for removal of pessaries. Okay, understand. What is the most common? They feel discomfort, something in the vagina, something in the lower pelvis, and they cannot have proper intercourse. That time they'll have its removal. Then, this is also correct. Third one, causes vaginitis and vaginal ulceration. Very true. If not maintain its hygiene. There was a patient who came almost like 2 years after the ring pessary insertion. She had not got it removed, changed, nothing. So much of ulceration, fungal growth, it had got impacted there. It didn't even come out easily. It had to be removed under anesthesia. So it was so difficult. Normally, pessary insertion doesn't require any anesthesia. It is done as an OPD procedure. Just like how we do PV examination, same way we can insert it. But this patient got impacted. It was fully infected, ulcerated also. It was so foul smelling also. I don't know how she stayed with that. So like that patients come. So vaginitis and ulcerations are very common. Okay. So only if they have not been removed in proper time and then replaced. Okay. Only if such cases, or not maintaining proper hygiene that time. Yes, it can cause vaginitis and ulcerations. Effective for stress urinary incontinence. yes, some amount of stress urinary incontinence, it is effective, but it is not the primary treatment, and not this ring pessary also. The ones with the knob having ring pessaries or gel horn pessaries, you would have seen. Even gel horn is not good. The knob ones, ring pessary with knob and without knob is there. Knob means there will be another structure, more larger structure which will press on the prevents it. No, it is not. So it is, well, it can be used, that's all. Okay, so it is not very effective. So this is one of the other reasons where we cannot, I mean, we do not want to use for stress urinary incontinence. It is used when the patient is very fragile, she cannot undergo surgery, or we want to buy some time to for the procedure to start or to do hysterectomy. That time we can use this as an alternative treatment. So it is not as a effective for stress urinary incontinence. So correct answer here would be D. Okay. Next question. A 32-year-old married woman presents for evaluation of infertility. Okay, infertility question. And what is the time duration? 1 year. If she is less than 35 years, more than 35 years, it is 6 months to start evaluating. Okay, so married women presents. Further investigation reveals intramural fibroid. Okay, there is an intramural fibroid measuring 7 into 5 centimeters and 5 into 3 centimeters, located in the right and the left corner. Okay, now you know this. Okay, this is the uterus. Okay, and right corner, left corner. So here there is almost right side how much? 7 into 5 centimeters and 5 into 3 centimeters on the right corner. What is the basic importance of the corner? Here is where the fallopian tubes are there, isn't it? Here is where the ostial opening is there. Now at the opening itself there are two fibroids. That means the osteas are blocked, isn't it? If you do HSG, what it will say? If, for example, had they given, I would do HSG, what would be the interpretation? Yes, there would be tubal blockage. Why? Because at the ostial opening itself, there is a two big fibroids, 7 centimeters and 5 centimeters, huge fibroids are there. Ostium is hardly 0.5 centimeters opening, isn't it? So that means again there is chance of blockage. There is no meeting of sperms and egg. There is no fertilization. There is no conception. So that is why, what is your treatment? Okay, husband seminal is normal. What is the most appropriate management? So what is your treatment? Yes, your treatment is to so your treatment is do the myoma removal, that is myomectomy, artificial reproductive techniques. Why you want to do when you have a procedure to do, let us say IUI or IVF you do, when there are so huge fibroids, the endometrial cavity is also distorted, the success will anyways reduce. So directly we would not go for that. We would first remove the fibroid and then try for artificial methods. Okay, then GnRH analogs, it will only cause temporary reduction. Once you stop the GnRH, again the fibroid is going to increase in size, isn't it? So you cannot give this also. Myomectomy, yes, this will be the definitive and most effective procedure for infertility. Okay, that is the reason why you should do myomectomy in this case. Uterine artery embolization would not help. So remember, uterine artery embolization cannot be used as a treatment of choice when fertility is a concern. When fertility is not a concern, okay, if they had given you history telling she has completed a family, then you can use uterine artery embolization, but not if a fertility is the concern. Okay, so correct answer here would be C. Next question. A 34 weeks pregnant woman presents with reduction of fundal height and decreased fetal movements. Okay, fundal height is less than the period of gestation and there are no fetal movements. Abdominal examination, uterus is full of fetus. I had told you even in the class, when in case of polyhydramnios, if it is poly, excess liquor is there, you cannot find the fetal heart rate, you cannot feel the fetal movements well. But same thing when it is uterus is less in size or oligo is there, that time you can fully feel the fetus. There is nothing you can feel between the uterus and the baby. It is like full of fetus everywhere, the baby only you can feel, and on top of that the baby cannot move because there is no liquor. Both the complaints they have given. So now your case of diagnosis is oligo. Let us see the question again. Ultrasound reveals the following findings. Which of the following fetal presentation is most commonly associated in this condition? Okay. Now, as we have told you, oligohydramnios, in that case, baby could not move properly. So, buttocks will come off down. It cannot move, so it doesn't go up at all. Usually, rotation happens nearing term, isn't it? So, here the buttocks would have just come down, will not go up because there is no liker for it to go, isn't it? There is no movement. Whereas in poly, what will happen? It will be changing like one time when you see it will be buttock, one time when you see it will be head, one time it will be empty lower pole. It will be moving so much that you cannot tell what is the position or presenting part at all. Okay. So in polyhydramnios, it is changing position. There also malpresentations and malpositions are very common. Whereas in oligo, it will get fixed. Breech will get fixed most commonly. In this also you can see the buttocks are down, isn't it? It is not the head, the buttocks, the spine, the buttocks are down. This is the cervical opening. So that means this is the case of breech presentation. Yes. Transverse shoulder face, anything. Face is not common. Shoulder transverse anything can come. Transverse is more common in septate or in case of uterine anomalies. Okay. Shoulder presentations or transverse is very common if the uterine anomalies are there. Whereas in oligo or poly, most common would be breech presentation. Even if you could not diagnose on the scan photo per se, you can diagnose on the just by history and knowing the concepts. Okay. Okay, next question. A 24-year-old primary gravida in spontaneous labor is admitted to the labor ward. The obstetric resident asks the nursing officer to initiate WHO labor care guide for the monitoring of labor progress. Okay, so now she has spontaneous labor and in ward, though the photo is not a case of a WHO labor care guide. This is the older pathogram or the which one, the one which had alert and an action line. From which cervical dilatation should the plotting of the pathograph begin? So this is just for confusing you. Is this the new one? Is this the WHO labor care guide that you have read? No, this is the older pathogram. Okay, this was the pathogram that we were using when we were PGs. Now we do not use this. Why? We have WHO labor care guide. Okay, in this, from what centimeter have they started marking dilatation? X. They started marking from 4 centimeters. Whereas the WHO labor care guide, this is just to confuse you. Okay, it is already given here 4. Then the answer will be 4 only. No, it is just to confuse you. First of all, it is not a WHO labor care guide. And this is the older one where 4 centimeters we started marking. But as per the newer one, the WHO labor care guide, we mark from 5 centimeters. Yes, this is the correct answer. C. Next question. A 24-year-old lactating woman, 7 months postpartum. Okay, she is 7 months postpartum, presents for contraception. She has regular menstrual cycles and no significant medical history. Okay, and which of the following is the most appropriate contraceptive method? Okay, depot injections, that is your norethistron ethantate, mala N oral tablets, copper T progestat. Since she's crossed 6 months of lactation, now you can give her any medications. Everything is true and correct for her. If she was in less than 6 months, we would not give mala N because estrogen we don't give when she is only breastfeeding. Correct? No. So estrogen we don't give. So now the answer or the question for you would be, which among these other, now that you can give everything, what you want to give? So they've asked most appropriate. That means which is amongst this, which is the one which large. That is long acting which has got the maximum amongst this is this copper implanon highest 380A almost 10 years. Okay, it has 10 years validity and it is the highest success rate with less failure rate. So that is the most appropriate one which you can use, and it is reversible as soon as you remove also. If there was implanon, that is for 3 years, but amongst copper T and implanon is the better rate, almost same, but implanon is better percentage. Okay, so that time you would have chosen implanon. Okay. And remember, Implanon can be given even when she is breastfeeding, only lactation. That first 6 months of period also she can use. Copper T also she can use. Implanon also she can use. Estrogen containing ones only she cannot use. Okay. Next question. A woman at 10 weeks of gestation with history of 3 consecutive first trimester miscarriages is found to be positive for lupus anticoagulant. Okay, what is this? Lupus anticoagulant anticardiolipin antibodies on repeat testing 12 weeks apart. So she's a case of APLA, antiphospholipid antibodies syndrome. Correct? No. So she's a case of APLA. So for you to remember, so much history I have given so that you know that 12 weeks. Okay, it should be done. At least 2 reports should be positive 12 weeks apart. If they give you just 1 report is positive, don't label her as APLA. At least 2 reports should be there. That too 12 weeks apart. Then only you should label her as APLA. Okay. The most appropriate management to improve her success. Now, without seeing options, you should tell me this answer. Yes, we have read this topic so many times. You should tell me this. It is? Yes, it is. Low molecular weight heparin. Yes, and plus aspirin. High dose corticosteroids. No, steroids would not help us here. Low dose aspirin plus heparin. Yes, answer would be B. So aspirin alone or heparin alone is not the option. And instead of heparin, if they had given you low molecular weight heparin, your correct answer would be that one. Okay. Low molecular weight heparin plus aspirin would be your correct answer. Okay. Okay, next question. A 28-year-old primary gravida with severe rheumatic mitral stenosis and atrial fibrillation presents at 10 weeks of gestation. She requires anticoagulation to prevent thromboembolism. Okay, now the same thing again, similar topic. 10 weeks of gestation. She is requiring anticoagulant to prevent thromboembolism. Which of the following statement regarding anticoagulant therapy in pregnancy is false? Your concept on anticoagulant to refresh that. Okay. Low molecular weight heparin is preferred during first trimester. True or no? Yes, it is the drug of choice. Okay, if she's a case of APLA positive, then as soon as cardiac activity is seen, as soon as UPT is positive, you will start her with low molecular weight heparin. Yes. Warfarin is used in first trimester, is associated with warfarin embryopathy. Yes, that is the reason we do not give. Though it is very good effective, we do not give in first trimester. Okay, that is the reason it is not advised in first trimester. It can be given from second trimester. So again, this is correct answer. Warfarin is usually started in the second trimester until near term. Yes, we start from second trimester until 36 weeks. So from 36 weeks, again we will convert it into low molecular weight heparin. Warfarin is oral tablet, easy compliance to the patient, and also it is affordable better. That is the reason only we start warfarin. Okay, this is also correct. Warfarin therapy is contraindicated during breastfeeding. No. After delivery, the drug of choice would be warfarin only. Okay. We will do bridging therapy for at least from day 5. Another for 2-3 days we'll do bridging. And then we will start her on only warfarin. So this is wrong. During breastfeeding, it can be given. It is not contraindicated. So this is wrong. So correct answer for this question would be answer D. Okay, next question. A 28-year-old married woman who is eager to conceive presents with profuse vaginal discharge without associated itching or foul smell. Okay, there is no itching or no foul smelling. So one of the signs of physiological, that means. Okay, then her last menstrual period was 13 days ago. That means furthermore, 13 days ago means now on 13th or 14th day, what she'll be having? She will be ovulating, isn't it? Now that she is ovulating, there is ovulation, there is mucoid discharge, sticky discharge, the billing test, everything you know, right? No. Which of the following is likely cause for discharge? Okay, I've already told the answer. Yes, trichomoniasis infection. Okay, it is strawberry vagina. Metronidazole is the treatment. So many times that picture, everything has come. You should remember. Treatment is metronidazole. You should remember. Physiological changes. Yes, this is the physiological discharge. There is no smell. There is no itching. There is no pain abdomen. That means it is a physiological discharge. That too, it is happening at the time of ovulation. Furthermore, it is a sign of ovulation. That's all, isn't it? Bacterial vaginosis? No, it is not bacterial vaginosis. And candidiasis, how will it be? It will be curdy white discharge, and it is associated always with itching. Okay, so all of them are wrong. Only correct answer is B. Next question. Which of the following drug is commonly administered to improve the success rate of external cephalic version? Okay, so external cephalic version, though it is not administered compulsory, that it is not a mandatory drug, but to increase the success rate for the easing of rotation, what we can do? Okay, let us tell uterus is contracting, so at that time can you move the fetus? No, you cannot. Let us say uterus is well relaxed, at that time can you move the fetus? Yes, easily you can move. When you're doing palpation, you'll hold the fetal head. If you do like this, it's moving. When your baby is under contraction, okay, when patient is in labor, that time you try and move. During contraction, you cannot move, isn't it? So relaxation is required. So let us see which drug will cause relaxation. Terbutaline? Yes, terbutaline is a tocolytic, isn't it? So tocolysis is there because of this. So it is the drug of choice. You can use terbutaline. It is not mandatory, but you can use to increase the success rate. Misoprostol, oxytocin, methylergometrin, all of them are causing uterine contraction. They are inducing labors. How can you turn when the baby is getting contraction, isn't it? So directly you can tell all these cannot be used because they will increase the contractions of the uterus. That time you cannot even try to palpate the fetal parts. Leave about the rotation, isn't it? So you want relaxation. So terbutaline is our beta 2 agonist, which will cause uterine relaxation, tocolysis. So you can use terbutaline. Next question. A 30-year-old multigravida at 34 weeks of gestation presents with painless vaginal bleeding. Now, I have taught you antepartum hemorrhage now also during quick revision. 34 weeks. That means she's still pregnant. She's having painless vaginal bleeding. You have done with your diagnosis. Yes, it is placenta previa. Whether you see the image or no, yes, now you know the painless vaginal bleeding antenatally is placenta previa first. On perspeculum examination, placenta is seen in the tissue protruding through the cervical internal os. What is the most likely type of placenta previa in this condition? Okay, as we have discussed, presently we have only two things. One is low-lying placenta, as in that of the first figure. One more is central placenta previa. Only these two things we have, isn't it? Either it is partially covering, completely covering, whatever it is placenta previa or low lying within 2 centimeters of this margin. Within 2 centimeters, if it is there, then it is low lying, or if it is covering the os, then it is placenta previa. So the D, previously we had anterior, posterior, all those things. Now you don't have the headache. It is only central placenta previa. So the correct answer here would be D. Next question. A patient presents with lower abdominal pain. Okay, the video shows transvaginal ultrasound appearance of the left adnexal cystic lesion. Okay, so it is now there is a cystic lesion. Here also we can see. Okay, there is a cystic lesion. If you can pause the video, you can see this one. When I did, it could be paused. Now I don't know why it is not able to pause. You can see the uterus and you can see the space and you can see a longitudinally elongated. So, for example, okay, ultrasound, based on the ultrasound demonstration, what is the probable diagnosis? Yes. So if you could pause the video in your exam, you can see like this, and it is a longitudinal swelling. Okay. So whenever it is a longitudinal swelling, you should first think in terms of fallopian tube damage. When it is cystic like this round, okay, that is mostly ovarian pathology. And usually there is some amount of distance between these two, but if it is adherent to that of the uterus, but it cannot be told like that also for you, because what happens when the ovarian mass is very huge, it will come adherent to that of the uterus also. Okay, so it is on experience that you can see the uterus and it is longitudinally elongated. Okay, so this is a case of fallopian tube damage. Follicular cyst, it will be a clear cyst, simple cyst. There is no septations like this, or there is no markings like this. Okay, this is with a septum. This horizontal septum also is there. Malignant ovarian cyst, that means there should be solid lesions. It should be bilateral. It should be very huge, and it is not having acoustic shadow. So many other rules. The M rules also we have discussed, isn't it? All those things will be there. So these two are not the answer. Hydrosalpinx, since it is very close and it is longitudinally elongated, elongated. We'll think in terms of hydrosalpinx. Hemorrhagic cyst will have this hemorrhage. This whitish marks will be there inside the cystic collection. Okay, there will be white, hazy. It will be not so clear. Okay, so that time it is a hemorrhagic cyst. Okay, so the correct answer here is hydrosalpinx. Next question. A sustained estradiol level required to produce LH surge. Okay, first of all, LH surge to happen for how much hours or duration should the estradiol should be raised? It should be raised at least for 2 days. Correct? No. So you have seen the estrogen is there in the first half of the cycle. It will be there and then it will increase suddenly. This increase will be for at least 48 hours, 2 hours. Then this increase will cause negative inhibition, and here you can see the LH surge. Correct? No. So this should happen at least 48 hours and the value is 200 picogram. Okay. So this is just a memory based question, because every question cannot be clinical, every question cannot be image. There are certain questions which are memory based also, certain numbers that you have to remember, certain durations that you have to remember. That is why we have given this. So in the first half of the cycle you have estrogen, and second half of the cycle, once the LH is there, with progesterone which was low will start raising from the second half of the cycle. All these things, you know, the LH surge, it will take 36 hours. This duration is 36 hours, and from the start of peak it is 24 hours. Okay, 24 hours from the start of onset, the surge will be the 24 hours. So here the correct answer would be 200 picogram for 48 hours. Even if you did not know the value 200 picogram, try and search. There will be some other clue for your answer. Definitely there will be a clue for your answer. Okay, so like in this 48 hours that you knew, so now you can correlate the value. No, none of them had 48 hours. It was for 2 days before the estrogen will be peaking, then the LH surge will happen. Correct? No. So the correct answer here will be C. Next question. A 28-year-old preemie gravida at 30 weeks of gestation, undergoes atrial blood gas analysis during evaluation of a mild breathlessness. Okay, so I have discussed with you in the quick revision also the physiological changes, isn't it? At that time, what I told you, there will be the diaphragm would raise up as the pregnancy increases. Diaphragm will be raise up, and there will be some amount of breathlessness. What are the things that will raise? Yes, respiratory rate, mild increase will be there, and minute ventilation will be raised. Tidal volume will be raised. What are the things which will reduce? Functional residual capacity or reserve volume. These are the things which will reduce, isn't it? So we have told you respiratory rate is going to increase, minute ventilation is going to increase, tidal volume is going to increase. That means what will be there? There will be some amount of respiratory alkalosis. Let us see the value. She is hemodynamically stable. ABG is as follows. Okay, she has complained mild breathlessness and you have done of ABG. Okay, which should not be done, which is physiological basically. Okay, but still you have done and seen the values. PaCO2, the carbon dioxide is 32. That means it is on lower side. 27 to 30, 32 is the values that in pregnancy. And oxygen, that is higher side, that is your 95 to 105 is the oxygen values. That means she is hyperventilating. That is why oxygen is more and carbon dioxide is released of outside maximum. That is why carbon dioxide is low. Carbon dioxide will be lower side, whereas oxygen will be increased. This is called as respiratory alkalosis. And pH in pregnancy. What is the normal pH in pregnancy? 7.40 to 7.45. It is normal only. It is slightly on alkalosis side. Why? Because of this hyperventilation. To prevent alkalosis, the renal compensation would happen. Mildly reduced serum bicarbonate will be there. Nothing is major that it is so much drastic change. They're all mild changes which is physiological. Okay, mild serum bicarbonate will be reduced. Which of the following best explain these findings? Okay, I've already told you. Primary metabolic alkalosis. They have given you all of them are respiratory values. How can you say metabolic alkalosis from this? Isn't it? And there is no vomiting also. Due to vomiting they have given. So it is wrong. Chronic respiratory alkalosis with renal compensation. Yes, it is respiratory alkalosis. Why this happens? Because of which hormone? Yes, it is because of Progesterone. Yes, correct. It is because of progesterone hormone. This respiratory changes are seen, and because of this, you can see respiratory alkalosis is there and renal compensation. As we have told you, mild reduced serum bicarbonate. This is the correct answer. Acute respiratory acidosis due acidosis. Is it acidosis 7.44? Acidosis it should means it should be less than 7.35. Okay, so it is not acidosis. And increased oxygen demand. Oxygen already higher side. Okay, so it is wrong. Metabolic acidosis. Again, they've given acidosis. So easy to choose the option. Just read, analyze. You will be able to definitely answer the question. Just analysis is what is required. You know the concept, analyze the question, and you answer the questions. Okay. Next question. A patient at 29 weeks of pregnancy, that means ANC patient, presents with uterine contractions. So at 29 weeks, somebody is having contraction. That means she is in preterm labor, isn't it? Now you know she's a case of preterm labor. Speculum examination reveals pool of vaginal fluid. That means she has undergone leak also. There is leak. That means it is PPROM. Premature preterm rupture of membranes. Okay. Cervical swab is sent for culture. Okay. First thing you should do for any case of PROM, PPROM is do a speculum examination and send swab for culture sensitivity. Okay. Which organism should specifically be screened? So for that, which are the common organism or dreadful organism are the reasons, isn't it? E. coli we generally don't do. That is a normal bacteria we do not do. Mycoplasm, yes, this is a must do. Okay. And chlamydia trachomatis, sorry, just a second. Mycoplasm we do not do. I'm sorry. So what we do is Chlamydia trachomatis, the most common infection causing ones. Okay. Chlamydia trachomatis and group B streptococci. Okay. Group B streptococci. The correct answer is B here. Okay. So it is Chlamydia trachomatis and streptococcus B because we do not want the fetus to suffer from GBS syndrome, isn't it? Group B streptococcal infection. So that is why group B streptococcus we always do. Along with this, Chlamydia trachomatis can be done. Other infections are very uncommon, not specific treatments are there, so we do not do. Candidiasis would not cause PPROM, that's why we would not do here. Okay, so correct answer here is B. Next question. Identify the maneuver demonstrated in this video. Yes. So now which side is the delivery? Is this side, is the head delivered or the buttocks delivered? Which of them has got delivered? See, the pubic bone, everything is up. No, the ileum, ischium, everything is up. That means this is the one which is delivered. This is the lower border of pubic symphysis, ischial tuberosity. So this is the one which is delivered. So the buttocks are out, shoulders are struck. So if I tell you buttocks are out, shoulders are struck, that means definitely you will tell. Had you got confused, the head is got delivered, it is shoulder dystocia, then you will think in terms of McRoberts maneuver. That is the first thing we will do, no? For McRoberts, suprapubic pressure. So, and rotational maneuvers, Woods, Cox, Rubin's maneuver. But remember here, the buttocks are this side. Buttocks have got delivered and the shoulder has got stuck. So that means for Burns-Marshall is for what? Even the head is got stuck. Pinard's for is what? For P for Pinard's, P for popliteal fossa, legs. And Lofset's is for the shoulders. Yes, this is for the shoulders. And Mauritius Malley-Wyatt method, again it is for the delivery of the head. So the correct answer here would be C. So this is all about the OBG questions. I hope you have understood well and you have recollected all of your knowledge that you have got and you have answered well in your exams. Okay, just remember doing multiple tests, mock tests, analyzing your mistakes, avoiding them will give you maximum marks. Okay, so basic important thing that you have to do is analyze your mistake, attempt all the grand tests or mock tests and then take benefit of that because there are so many tests available. Please take use of that. Again, next Sunday we have one more grand test. I want maximum number of students to attempt that because when you attempt these exams, we have maximum amount of benefit for you. Okay, so when you are attempting, you will know where you are going mistake. For example, similar way of reading wrong wrong question. Reading it, removing the false, or reading, picking up the important points will come only by answering these questions. Okay, do multiple tests, revise multiple times. Do not try and attempt reading any new topics now. You hardly have another 20 days. Okay, it is not the time to be scared. It is the time to be calm and composed. Now you show your dedication, results will automatically be your side. Okay, all the best students. Now take a 2 minutes break and we'll start with our pathology discussion with Dr. Madhu ma'am. All the best. Thank you.
ठीक। नहीं, मेरे को एसी चाहिए। आप चला लेना, कोई बात नहीं। मुझे गर्मी लग रही है बच्चों, चलाऊंगी, आप चला लो। All right. So I hope you had a fruitful and a long session. I know all of you must be tired after such a long session of medicine, surgery, OBG. I'll be very quick. We'll discuss the pathology, physiology, and microbiology questions that were asked in your first GT. I would rate the paper, at least for the pathology, physiology, and microbiology, moderately difficult. They were not very simple questions. They were not the routine PYQs or from the routine HYTs. It is good for you. You got the exposure of new questions, probable potential new questions. So let's start with the first question. A 55-year-old male from Kashmir presents with a painless carotid bifurcation mass. Histology shows Zell-Bollen architecture with chief and spindle stromal cells. Immunohistochemistry is positive for chromogranin, synaptophysin, NACs, CD56, CD57. Which marker is most likely positive in the supporting stromal cell? So they're not asking you for the diagnosis. You already know the diagnosis since it is from Kashmir. It is from Kashmir. It shows Zell-Bollen architecture and the immunohistochemistry is positive. The chief cells are positive for your chromogranin, synaptophysin, NAC, CD56 and CD57. They are asking you which marker is likely to be positive in the supporting stromal cell. So I hope all of you know the diagnosis. Can anybody tell me what is the diagnosis? Right. The diagnosis is basically your carotid body tumor. Okay. The diagnosis is carotid body tumor or paraganglioma. Most common location, it is at the, yes, bifurcation of the common carotid artery. They've already told you carotid bifurcation mass, so bifurcation at the common carotid artery, and it has Zell-Bollen architecture. The chief cells are positive for chromogranin, synaptophysin, NSC, CD57, And the stromal cells, yes, we all know the stromal cells are the supporting cells which surround your Zellbolen mass. What is exactly Zellbolen mass? It's basically a cluster of balls of neuroendocrine cells. Carotid body tumor or paraganglionoma, they arises from the neuroendocrine cells. So the cluster of neuroendocrine cell, the surrounding cells are known as the stromal cells, and these cells are positive for, yes, these cells are positive for your S100 protein. Okay, these cells are positive for S100 protein. Also, they are positive for SOX10. Okay, this is a new marker. SOX10 is also positive in stromal cells. The chief cells, all these hormones are positive. That's what they already told you, right? All right. Zellbolen, why is it called Zellbolen? It's basically the German name for the cell balls. It's a German name for cell balls, the tumor cells balls, right? They are arranged in nests and clusters. All right. Moving to the next question. A 45-year-old male presents with chronic diarrhea, weight loss, intermittent abdominal pain, migratory joint pains for several months. He also complains of fatigue and skin darkening. On examination, there is hyperpigmentation of the face and neck. Duodenal biopsy shows foamy macrophages in the lamina propria, which are PAS positive granules. What is the most likely diagnosis? Again, you have to see the classical clinical pictures. Signs of malabsorption. See, signs of malabsorption. What are the signs of malabsorption here? Chronic diarrhea, weight loss, and rheumatological features, migratory joint pains, polyarthritis, then hyperpigmentation. Okay, so these are the classical picture of your, yes, these are the classical picture of your Whipple's disease. What is the organism? The organism is basically, yes, Tropophinema whippleyi. Okay, and these foamy macrophages, what are these foamy macrophages that you see? Basically, these are the debris of your these are the debris, so bacterial debris within the macrophages, that is seen as foamy macrophage. And these are PAS positive and diastase resistant granules. PAS positive and diastase resistant granules. Okay. What will you see in Crohn's disease? Looking at the other option, what will you see in Crohn's disease? You will see granulomatous inflammation. Okay, rather than foamy macrophages, you will see granulomatous inflammation, non-caseating, right? Non-caseating granulomas. Celiac disease, again, what will you see in celiac disease? You will see basically villus atrophy, right? What will you see in celiac disease? You will see villus atrophy. I'm sorry. Villus atrophy. And intestinal tuberculosis, very simple. What will you see? You will see caseating granulomas. Caseating granulomas. And moreover, in intestinal tuberculosis, it is the area affected more commonly is the ileocecal region. So here the answer is foamy macrophages and the symptoms of malabsorption, rheumatological involvement, hyperpigmentation, PAS positive granules in the foamy macrophages. It is Whipple's disease. All right. Moving on to the next question. A patient with cirrhosis and ascites presents to you. The gross appearance of the liver is given to you. Which of the following statement about it is correct? Okay, they've given you the image. They've given you the image. If you see dark and pale areas. What is the characteristic? What is the image? It is your nutmeg liver. Okay, nutmeg liver. And nutmeg liver is basically due to the chronic congestion and ischemic injury, right? Most probably due to, it is hepatic congestion or chronic congestion and ischemic injury. What do you see here? You see alternate areas of dark and pale areas, right? Alternate dark and pale areas. So dark areas will represent necrosis and pale areas will represent the viable, yes, the viable liver tissue. So what is the option here? Dark areas represent necrosis and white area represents viable liver tissue. So dark area, your reddish brown area is basically which area? It is your, right, it is your zone 3 or pericentral zone surrounding the central veins, and this area basically receives the blood last, so it is more prone to necrosis. White area is zone 1 area or the peritubular area, right? Periportal, sorry, periportal area, periportal, surrounding the portal triad. So they will receive the blood first and they will have pale areas. So it is dark area, necrosis, white area, viable liver tissue, nutmeg liver, right? Moving on to the next question. A 22-year-old male presents with nephrotic range. There's proteinuria, microscopic hematuria, and reduced GFR. The renal biopsy reveals segmental sclerosis affecting portion of some glomeruli. The electron microscope shows widespread podocyte foot process effacement. He does not respond to corticosteroid therapy. Family history reveals consanguinity. Which of the following mutation is most likely to be associated with this condition? So, before we move on to what mutation is affected, can anybody tell me what is the diagnosis? See, we have segmental sclerosis, right? Podocyte portion of glomeruli, that's segmental sclerosis. Then there is widespread podocyte foot process effacement. So most probably it is your focal segmental glomerulosclerosis. He does not respond to corticosteroid therapy. Again, an indicator to your focal segmental glomerulosclerosis. Then family history reveals consanguinity. So it is most probably an autosomal recessive pattern. Okay, autosomal recessive pattern. Now, which mutation is responsible? We all know for focal segmental glomerulosclerosis, the mutation is your NPHS2 mutation encoding protein, right? I hope all of you remember this. This is the mutation responsible for your focal segmental glomerulosclerosis. Now, NPHS1 mutation encoding protein, where is it found? It is found again in your congenital nephrotic syndrome. Remember, again, it is congenital nephrotic syndrome. I'm sorry, there's some problem. Just give me a second. Yeah, congenital nephrotic syndrome, and it will not be seen in a 22-year-old male. It will be seen in younger age group, right? Then COL4A5 mutation, alpha encoding alpha 5 chain type 4 collagen. We all know it is your Alport syndrome. Okay, Alport syndrome. And what will you find in Alport syndrome? The classical triad, you'll get ocular abnormalities, sensory neural hair deafness, and moreover, it will be X-linked, right? Congenital nephritis, sensory neural deafness, and yes, ocular abnormalities, X-linked recessive, right? So this is again not the answer. WT1 mutation is seen, and again it is seen in patient of focal segmental glomerulosclerosis, but there would be additional Wilms tumor and ambiguous genitalia, which is not here. So our correct answer here is congenital focal segmental glomerulosclerosis with NPHS2 mutation encoding protein, right? Moving on to the next question. A man presents with a midline neck swelling that progresses to cervical lymph node enlargement. Histopathology of the lesion is provided. Which of the following statements about this condition is incorrect? So they've given you the picture. If you see the very clearly, you can make out the papillary structure. Okay, you can very clearly make out the papillary structure, and even if you zoom this image further, you will see basically the optically clear nucleus here. And somewhere you will see the nuclear grooving also, the coffee bean appearance. So your diagnosis is papillary thyroid cancer. Now, what does this question ask? Please note question में पूछा क्या जा रहा है. It is correct, incorrect, all are true, or which is false. You have to read the question very thoroughly. What are they asking? So here they are asking about the incorrect statement for papillary thyroid cancer. It spreads quickly via lymphatics. Yes, it is true. And moreover, this patient is presenting with cervical lymph node enlargement. Fine needle aspiration cytology is not a diagnostic method. This is incorrect. Okay, so this is a correct option here. Fine needle aspiration cytology is the gold standard, is usually the gold standard for your papillary thyroid cancer, because all the nuclear features, the orphan annii nucleus, the optically ground glass appearance of the nucleus, your coffee bean appearance, everything can be seen on the FNAC smear, right? So this is the incorrect statement and your correct answer here. Excellent prognosis is associated with this condition. Again, a true statement. Nuclear characteristic are used for identification. Yes, of course. Orphan annii nucleus, sabko pata hai, orphan annii nucleus is one of the favorite questions for your examiners. So papillary thyroid cancer, follicular medullary. तीनों में से कुछ ना कुछ जरूर आता है, right? Your papillary eye, your orphan annii eye, or your owl eye appearance. दोनों questions, any form, they will definitely come in your exam. ठीक है? So उनके बारे में anything can be asked. All right? Okay. Moving on to the next question. Match the following types of glomerular disease with the corresponding electron microscopy finding. I found this question slightly complicated, but अगर आप देखोगे match the following, एक एक करके match करोगे, तो it is very simple. Membranous nephropathy में क्या होता है? Can anybody tell me what is there in membranous nephropathy? What is there in membranous nephropathy? You will see subepithelial deposit with spike and dome pattern. ठीक है, तो ये हमारा ऑप्शन कौन सा हुआ? membranous nephropathy, spike and dome pattern. Okay, they are not mentioned dome pattern, but it is subepithelial deposit, spike and dome pattern. Minimal change disease, without any minimal change, but there is effacement of food processes. ठीक है, so again B is with 2. Now, membranoproliferative glomerulonephritis type 1, we all know subendothelial deposit hota hai, and what appearance is there seen here? Tram track appearance, right? So this is again the correct answer option. Acute post-infectious glomerulonephritis, subepithelial hump-shaped deposit, again, they are matching same by same. Dense deposit disease, so you see intramembranous dense deposits. So A का 1 है, B 2, C 3, D 4, E is 5. So what are the options available? Yes, it is the first option only. Membranous nephropathy, you see spike and dome pattern, subepithelial deposit. Minimal change disease, effacement of food processes. Membranoproliferative glomerulonephritis type 1, tram track appearance, subendothelial deposit. Acute post-infectious glomerulonephritis, you see subepithelial hump. And right, dense deposit, then you have intramembranous dense disease deposits, right? So this is very clear, simple. Moving on to the next question. As an intern, you're expected to select the appropriate vacutainer for different laboratory investigation. The image shows one such vacutainer. What is the content of additive of this vacutainer? So how do you identify the purpose of a vacutainer, for what tests they are used? By the color coding of the vacutainer top. यहाँ पे क्या है? Red. Okay, vacutainer के questions हमेशा INI set में regularly पूछे जाते हैं, but then you should be prepared. NEET PG, anything can be asked. So vacutainers, please do remember, and vacutainers के लिए I have prepared this table. Very simple, easy to understand. You have to see कौन सा top है. Red color top है तो anticoagulant, clot activator. It is used for your serum biochemistry test, your serology test. Light blue, Remember, light blue, the anticoagulant is sodium citrate, but in a ratio of 1:9. Even black may be sodium citrate hota hai, but it is in a ratio of 1:4. Light wala, it is used for your coagulation study. Again, very, very important. They do ask you coagulation profile ke liye, which colored Vacutainer is used. It is light blue, right? And the black with sodium citrate 1:4 is used for ESR. Now, the purple lavender, the bread and butter of hematologist, it is EDTA, used for all your hemat test and for blood typing also. Green, heparin, plasma chemistry, blood gases. Gray is sodium fluoride plus potassium oxalate, used for glucose, lactate, and alcohol, right? And light pink is again EDTA, it is potassium EDTA or blood bank test, right? Golden is clot activator plus gel for your hormone assays, enzymes, and lipid analysis. Yellow is the anticoagulant is ACD or SPS, and it is used for blood culture and HLA typing. Black, I already told you, sodium citrate 1:4 in the ratio of 1:4 and is used for ESR. Now, coming back to the question, हमारा कौन सा Vacutainer है? It is your red. So, it has to be clot activator. All right? It has to be clot activator. All right. Moving on to the next question. In a pedigree chart showing only female carriers and only males are affected, which condition is most likely? See, this representation, female and a dot, suggest a carrier. This is affected when it is fully shaded. All right. So this is a female carrier, males are affected. So is disease may males are affected, only males are affected, and all the females are carrier. So it is an, yes, it's an X-linked recessive disorder. Okay, X-linked recessive disorder. तो X-linked recessive disorder इसमें से कौन सा होता है? We all know it is Wiskott-Aldrich syndrome. It's an X-linked recessive disorder characterized by eczema, thrombocytopenia, and recurrent pyogenic infections. Right? Now, Prader-Willi syndrome में क्या होता है? Oh, 1 second. What is there in Prader-Willi syndrome? Prader-Willi syndrome में basically there is paternal deletion of a portion of 15 genome 15q11. Okay, 15q11, but paternal from the father. Okay, remember how did we study? Prader का paternal. अगर maternal होता है from the 15q, it is Angelman syndrome. Okay, maternal ka M, Angelman, paternal ka P is Prader. So again, this is not the answer. This is not an X-linked recessive. Wilson's disease. Wilson's disease is autosomal recessive. Okay, autosomal recessive. And achondroplasia is autosomal dominant. All right. So here the answer is Wiskott-Aldrich syndrome. It is X-linked recessive. X-linked recessive. That is why females are carriers and males are affected. How did we remember the X-linked recessive diseases? Just remember, females will always give her boys her X-linked disorders. So, X-linked disorders, female will have X-linked disorders. They will be the carriers, but they will always give her boys her X-linked disorders. Okay? Females will always give her boys her X-linked diseases. Fabry syndrome, W, Wiskott-Aldrich syndrome, which was the answer here. Then A is ocular albinism, G6PD, hemophilia A and B, we already know, Bruton's A gamma globulinemia, Hunter's disease, X-linked severe combined immunodeficiency, and Duchenne and Becker's muscular dystrophy, right? So here the answer was the females are carriers, males are affected. The answer was Wiskott-Aldrich syndrome, right? Moving on to the next question. A 55-year-old woman with advanced breast cancer is started on drug that inhibits CDK4 activity. Which genetic alteration? Now, which genetic alteration here is the therapy that is most directly translated to? Now, we all know therapy for, over a 55-year-old woman with advanced breast cancer is started on a drug that inhibits CDK4 activity. With genetic alteration is this therapy most likely targeted? We all know that in breast cancer, it is the retinoblastoma gene that is affected. If no, it is not the retinoblastoma gene, but it's the overexpression of cyclin D, right? Which combines with your CDK4 and 6 to phosphorylate retinoblastoma gene. Now, phosphorylation of retinoblastoma gene, your ETF is released. That causes DNA synthesis, and the S phase in your cell cycle will be continued. That is, because of overexpression of this in breast cancer, your cells will go proliferation, the unchecked proliferation will be there, right? And what is your retinoblastoma gene known as? It is the gatekeeper of the cell cycle. Okay, it is your gatekeeper of the cell cycle. And after its proliferation, after its phosphorylation, the G2S phase cycle continues, and basically there is controlled check of the tumor cells. So a correct answer here is overexpression of cyclin D genes, which combines with your CDK4, resulting in retinoblastoma gene phosphorylation and hence uncontrolled cell cycle proliferation. Now, point mutation of JAK2 leading to constitutive growth signaling. This is not usually seen in breast cancer. This is seen in your myeloproliferative tumors. Okay. Loss of MYC regulation via immunoglobulin enhancer translocation. This is usually seen in your Burkitt lymphoma. Okay, this is seen in Burkitt lymphoma. Then inactivation of RB protein at the G2M checkpoint. First of all, it is not the inactivation, it is activation. And G2M nahi hota, G2S hota hai, right? So a correct answer here is overexpression of cyclin D genes due to translocation amplification. All right, moving on to the next question. A girl presents with the following features: short stature, webbed neck, thick calves, shield-shaped chest, ankle swelling, and an increased carrying angle. What is the most likely diagnosis? So हमारे पास short stature है, webbed neck है, thick calves है, shield-shaped chest, ankle swelling, increased carrying angle, or your cubitus valgus. Okay, cubitus valgus. So what is the diagnosis here is? Yes, the diagnosis here is Turner syndrome. All the characteristic features: short stature, webbed neck, cubitus valgus, thick calf, shield-shaped chest. It is Turner syndrome. Now, Turner syndrome, what is Turner syndrome? It is 45XO. Okay, this is Turner syndrome. Looking at the other option, Down syndrome में क्या होता है? It is your trisomy 21. And what are the characteristic features that you will see? Basically, you will see intellectual disability. You will see congenital heart defects or single palmar crease. ठीक है, तो ये सारे questions में अगर features होते हैं तो it is trisomy 21. Pettau syndrome, what is Pettau syndrome? It is your trisomy 13. What will you see? You will see microphthalmia, cleft palate, cleft lip, polydactyly, right? Edwards syndrome is trisomy 18. What will you see? Micrognathia, you'll see rocker bottom feet, you'll see, basically you'll see clenched fist here. So this is your Edwards syndrome. यहाँ पे correct answer is Turner syndrome, right? Moving ahead, next question. An elderly male went for a medical examination. Lab investigations showed marked elevation of lymphocytes with marked leukocytosis. The peripheral smear of the patient is given below. What is the most appropriate next step for this patient? If you see the peripheral smear, यहाँ पे क्या दिखाई देता है? Basically, what else? What will you see? You will see small mature lymphocytes. Okay, small mature lymphocyte. And what is this cell called? Yes, this cell is called your smudge cell. Smudge cell or crushed little lymphocyte. Crushed little lymphocyte. Again, आपका diagnosis बन गया CLL. Okay, smudge cell or crushed little lymphocyte CLL. Now, what is the appropriate next step for this patient? Would you directly give to bone marrow transplant? Would you directly give stem cell transplantation? No, not stem cell transplantation. It does not have any role. Bone marrow biopsy? No. Bone marrow biopsy is not, it's an option. It is not a mandatory feature. It's an optional feature for diagnosis of CLL. What is the mandatory feature in the diagnosis of CLL? It is your flow cytometry, right? And unless and until you give the diagnosis, you cannot start high-dose chemotherapy. What is the diagnostic requirement for CLL? We all know the absolute lymphocyte count should be more than 5,000 cells per microliter. Your flow cytometry, CD5 positive, CD23 positive. Okay, CD5 positive, CD23 positive, and your CD200 should be positive. Then bone marrow, you should have more than 30% of lymphocytes. But please note, bone marrow aspiration is optional. You need not do a bone marrow for diagnosing or for giving a diagnostic criteria of for CLL. Flow cytometry is the most important diagnostic criteria here. So our correct answer is flow cytometry. All right, let's move on to the next question. Okay, caspases play a crucial role in which of the following types of programmed cell death? This is a previous year question. Caspases are involved in which type of programmed cell death? Is it necrosis, necrosis and apoptosis, ferroptosis and apoptosis, necroptosis and apoptosis, pyroptosis and apoptosis? Okay, apoptosis में तो we already know apoptosis में तो होता है. Okay. Apoptosis, caspases do play a role. Ferroptosis, please note ferroptosis is an iron-dependent form of non-apoptotic cell death. Okay, it's ferroptosis is basically iron-dependent non-apoptotic cell death, and it is because of accumulation of lipid peroxides. Caspases are not involved there. Caspases are not involved. So caspases are not involved here. Necrosis mein again caspases are not involved. We all know apoptosis mein definitely it is involved. Here ferroptosis negative, apoptosis positive. Necroptosis morphologically resemble necrosis only. There will be cell swelling, there would be rupture of the membrane, but it is caspase independent. It is genetically controlled. It is caspase independent. Okay, caspase independent and is genetically controlled. Pyroptosis, on the other hand, it's highly inflammatory form of your programmed cell death. So apoptosis may highly inflammatory form is your pyroptosis, and this is dependent on your caspase 1. ठीक है, so हमारा caspase dependent cell death कौन सा हुआ? Apoptosis, yes, and pyroptosis. Okay, these are the two forms in which caspases play a crucial role. So D is the correct answer. All right. So very quickly revising, apoptosis, necroptosis, pyroptosis, and ferroptosis. Apoptosis में inflammation, no inflammation. It is a physiological death with the cell death without inflammation. Whereas necroptosis, pyroptosis, and ferroptosis, there will be surrounding inflammatory cells. Key enzyme, apoptosis में we all know caspases are there. Necroptosis में no caspase, it is RIPK1, K3, MLKL. Pyroptosis में caspase 1 would be present. And again, ferroptosis में caspases are not there. And membrane pores formed in all except in apoptosis. ठीक है, सो हमारा क्वेश्चन क्या था? कैस्पेसेस आर इन्वॉल्व्ड इन योर एपोप्टोसिस एंड पायरोप्टोसिस. All right, let's move on to the next question. A patient presents with vomiting, diarrhea, skin rashes that are resolved after switching to a gluten-free diet. Which enzyme deficiency is most likely? Now, vomiting, diarrhea, skin rashes resolved after switching to a gluten-free diet. So it is your gluten-sensitive enteropathy. It is your celiac disease. Okay, celiac disease में कौन सी enzyme deficient होती है? Very simple, anti-tissue transglutaminase antibody, right? Your dermatitis, herpetiforms, gluten-free diet, everything indicates to celiac disease. And the enzyme deficient is anti-tissue transglutaminase antibody. ANCA कहाँ पे positive होती है? ANCA is positive basically in your small vessel vasculitis, microscopic polyangiitis, वहाँ पे ANCA positive होगा. Antiparietal antibody कहाँ पे होगा positive? It's basically autoimmune gastritis or your pernicious anemia, right? Then ASCA, ASCA is your anti-saccharomyces crevices antibody, positive in your, yes, positive in your Crohn's disease. And how will you differentiate Crohn's and ulcerative colitis? Crohn's disease में ASCA positive होगा, ulcerative colitis में आपका P-ANCA positive होगा. Okay, this is how you will differentiate between ulcerative and Crohn's also. This is how you can differentiate ulcerative and Crohn's. So here the answer is celiac disease. The enzyme deficient is anti-tissue transglutaminase antibody. Let's move on to the next question. A patient presents with 1 month history of exertional dyspnea. Echocardiography reveals mitral stenosis, left ventricular hypertrophy. Identify the histopathological finding shown below and determine the most likely diagnosis. Right. सबसे पहले mitral stenosis and left ventricular hypertrophy. अगर आपने अभी मेडिसिन भी पढ़ा है तो उसका it is classical feature of your rheumatic heart disease. Okay, classical feature of rheumatic heart disease. And if you see the you see the histology, what will you see? You will see central necrosis here. And यहाँ पे ये कौन से cells हैं? Anishkov cells. Okay. And what is this entire body known as? Ashkoff body. Okay, Ashkoff body. And Ashkoff cells में आपको basically caterpillar shaped cells होंगे, wavy nucleus होगा. So the correct answer here is histopathologically you see Ashkoff bodies and rheumatic heart disease, right? Why is it not a non-caseating granuloma tuberculosis? This is a wrong option. Tuberculosis में caseating granuloma होगा, non-caseating नहीं होगा. Calcification of the valve, mitral stenosis, again, it's a gross feature. You cannot make it out on the histopathology. You will see only calcification. Granuloma, sarcoidosis, again, you don't see a granuloma here, right? So this is also incorrect. The correct answer is Ashkoff body and RHT. Right. Moving on to the next question. A 5-year-old child presented to the OPD with proptosis of the left eye. On investigation, a Desmond positive tumor was found. What is the most likely diagnosis? Now, Desmond positive tumor hai. What is the most likely diagnosis? And the patient presents with proptosis. Okay. So what is the most likely diagnosis here? Can anybody tell me? Is it leukemia, retinoblastoma? What is it? Yes, it is embryonal rhabdomyosarcoma. The diagnosis is embryonal rhabdomyosarcoma. Desmin positivity plus, if you see myogenin and myo-D1, all these are positive in embryonal rhabdomyosarcoma. Plus, there is proptosis of the eye. Leukemia may be proptosis of the eye hoga. What is the tumor that is seen in associated with leukemia? Chloroma or sarcoma, and it is associated with your AML-M2. Okay, but it is not Desmin positive. It will be MPO positive, वो तो होता ही है. Then it will be CD34 positive. Okay, so not Desmin positive. Retinoblastoma में क्या होगा? Retinoblastoma में synaptophysin positive होगा. NSC पॉजिटिव होगा एंड प्लस वहां पे आपको हिस्ट्री क्या दी जाएगी? ल्यूकोकोरिया की. ओके, ल्यूकोकोरिया की हिस्ट्री दी जाएगी. इविंग सार्कोमा में CD99 पॉजिटिव होगा एंड इट इज अ प्राइमरी बोन ट्यूमर. ऑर्बिटल इन्वॉल्वमेंट वुड बी वेरी लेस हियर, लाइक वेरी रिमोटली. So the correct answer here is embryonal rhabdomyosarcoma. All right. Moving on to the next question. Okay, let's discuss the physiology question. The pacemaker zone responsible for generating gastric peristaltic waves. Okay, gastric peristaltic waves, the pacemaker zone. The pacemaker zone, yes, it is the middle body of the stomach. The correct answer is the middle body of the stomach. That is your gastric pacemaker. Okay, gastric pacemaker. And what are the cells from which these peristaltic waves originate? These are your interstitial cells of Kejal. Okay, ICC, which are therefore act as the intrinsic pacemaker cells, right? Now, spontaneous depolarization in these cells occur at a rate of 3 cycles per minute. 3 cycles per minute, which propagate a ring-like peristalsis. Okay, ring-like peristalsis, which moves down towards the antrum and the pylorus. All right. Now, this is your middle of the body of the stomach. That is your pacemaker zone for generating gastric peristalsis. All right. Now, coming to the next question. A 42-year-old man undergoes PFT. His spirometry shows a forced vital capacity within normal limits. So FVC is within normal limits, but there is a reduced FE1 to FVC ratio. Reduced FE1 to FVC ratio of 62%. Which of the following best explain? Now, here what you have to note, your FVC is normal, but your FEV1 to FVC ratio is 62%. What is the normal FE1 to FVC ratio? Normal is more than equal to 72%. So यहाँ पे decreased है. ठीक है, FVC normal है तो क्या decrease होगा? Your FV1 would be reduced. This is reduced, that means it's a obstructive airway disease. Very good. It is obstructive airway disease because your forced expiratory volume in 1 minute is reduced. Could be asthma, could be chronic bronchitis. This is obstructive airway disease causing difficulty in exhalation. So this is a correct answer here. Let's look at the other option, normal lung function with age-related decline in this ratio. See, with age also, this ratio will decrease, but not up to 62%. This is far beyond low. Okay? So this is not age-related decline. Again, it is not a restrictive lung disease because your forced vital capacity is normal. So it is not a restrictive lung disease. It is not reduced forced expiratory flow because small muscles are affected here, not the larger muscles, right? So our correct answer is obstructive airway disease causing difficulty in exhalation. Moving on to the next question. A 65-year-old man undergoes bowel resection surgery. After the segment is removed, the surgeon observes that the isolated intestinal section continue to exhibit rhythmic contractions. So bowel has been removed, resection has been done. Still, the intestinal section continues to exhibit rhythmic contractions. What is the most likely explanation for this observation? Is it ongoing vagal stimulation? No, it is not ongoing vagal stimulation. Why? It is not ongoing because the supply has been cut off. Okay, the supply is cut off. Why? Because of the resection. The supply has been cut off. So it could not be ongoing vagal stimulation. Persistent spinal reflexes, again, no. Why? Again, because it has been, the section bowel has been resected. It is not in connection with your spinal pathways. So could not be persistent spinal reflexes. Intrinsic activity of the enteric nervous system. Yes, this is the correct answer. Intrinsic activity of the enteric nervous system. What is this called? Enteric nervous system intrinsic activity. What is this called? Often called the second brain. Okay, second brain. Why? Because it functions functions independently without the control of your CNS as well as without your autonomic inputs. Okay, second brain. Sorry, enteric nervous system is also called second brain because it functions independently without the control of your CNS stimulus or without the autonomic inputs. What does it consist of? We all know it consists of your, remember, MASM. MASM. M is myonteric plexus. Myonteric or Orbach's plexus. How can you remember? SM, myonteric Orbach's plexus, located basically between your longitudinal and the circular muscles, and it primarily controls your gastrointestinal motility. Second कौन सी होती है? Your submucosal or Meissner's plexus, located in the submucosa, and this regulates your secretions, absorption, and the blood flow. Myonteric regulates the movement, the motility, and submucosal regulates the secretion, absorption, and the blood flow, right? And these can have activity despite the cutoff from the CNS or the autonomic input, right? So the correct answer here is intrinsic activity of the enteric nervous system. रेसिड्यूअल हार्मोनल एक्टिविटी फ्रॉम द पैनक्रियास क्यों नहीं होगा? पैनक्रियास से सिक्रीशन कहाँ से आएगा? या तो ब्लड से आएगा, सिस्टमिक आएगा, या तो ल्यूमन से आएगा, एंड बोथ हैव बीन cut off. So this again is not possible. The correct answer is intrinsic activity of the enteric nervous system, right? Coming to the next question. What is the direct consequence of the parathormone inhibition of the sodium hydrogen exchanger in the proximal tubule? Okay, what is the direct consequence of parathormone inhibition? Now, before we arrive at the answer, what is the role of your sodium hydrogen exchanger? See, in the proximal convoluted tubule, this is your sodium hydrogen exchanger 3. Okay, now what does it do? This is your blood, this is your lumen. Okay, what happens here? Sodium basically, this exchanger basically secretes hydrogen ion. It secretes hydrogen ion in exchange of your sodium. So sodium goes inside the cell and hydrogen goes into the lumen. Now this hydrogen combines with your bicarbonic acid to form bicarbonate. Okay, this forms bicarbonic acid, and this helps in the reabsorption of your bicarbonate. This helps in the reabsorption of bicarbonate. Now, bicarbonate is reabsorbed with the help of your hydrogen. Hydrogen is basically secreted by your sodium hydrogen exchanger. Now, in case of parathormone inhibition, hydrogen will be not secreted. So, less hydrogen in the lumen, less bicarbonic acid formed. Less bicarbonic acid formed, less bicarbonate would be reabsorbed. Less bicarbonate would be reabsorbed, that means it will be wasted off. Less bicarbonate reabsorbed, that is less acidification of the urine. Okay, meaning less acidification of the urine because your bicarbonate is getting lost, right? So coming back to the options again, because of the parathormone inhibition of this exchanger, there would be reduced urine acidification. All right, simple, understood? Next question. A 52-year-old patient comes with progressively worsening episodes of chest discomfort and palpitations over the past 6 weeks. The pain is dull, pressure-like, and subsides with rest. So most probably it's angina. Which type of nerve fibers are primarily responsible for this type of deep visceral pain? So we all know fibers responsible for deep visceral pain are your C fibers. Basically, these are small diameter unmyelinated fibers. Okay, unmyelinated fibers, which are primarily responsible for your dull pressure-like pain. Poorly localized, dull pain. Okay, so the correct answer is C fibers. Now, A alpha and A delta fibers are basically large diameter fibers. Large diameter fibers, and they are responsible for touch, pressure, proprioception. All right. A gamma fibers. A gamma fibers are again medium fibers, medium diameter fibers, and they are responsible for controlling the muscle tone. Now we also have delta fibers. What do delta fibers do? Delta fibers are basically again small diameter only, like C fibers, they are small diameter, but they respond to fast or quick pain, sharp pricking pain. Like in fact, sharp pricking pains are the perception is received by your delta fibers, right? So deep visceral pain of the heart is by C fibers, right? Moving on to the next question. If the membrane potential of a cell is minus 80 volt, okay, membrane potential is minus 80 volt, which of the following ions will be the driving force? Which of the following ions will the driving force be highest and thus move rapidly into the cell? Now, they will move rapidly into the cell. What is the driving force? Can anybody tell me what is the formula for the driving force? The formula for the driving force is, yes, the driving force, the formula is where Vm is your resting membrane potential, E ion is the equilibrium potential for a specific ion. What is the Vm here? Vm, we all know resting membrane potential is minus 80 millivolt. Okay. Now, they've given you the ions and they've given you the equilibrium potential. You have to calculate the driving force. Maximum driving force ke liye you have to identify basically the magnitude or the number that comes after this formula will be the driving force. The sign here, minus or positive, indicates only the movement of the anion or cation within the cell. For cations, please note, for cations, a negative force, negative driving force that is less than 0 drives the cation into the cell. Okay. Here for anions, a positive driving force that is more than 0 will drive the anion into the cell. Okay, for cations, a negative driving force that is less than 0, the cation will move inside the cell. For anions, a positive driving force more than 0, the anions will move into the cell only. Okay, so minus or plus sign is basically the cation or anion moving inside the cell, but it is the number that we will get after solving this equation that will be the maximum drive. That will be the driving force. That will be basically the magnitude of the driving force. So here, if we see for calcium, it will be minus 80 minus 120. So the answer would be around, yes, 200. Okay. For sodium, it will be minus 80 plus, minus 80 minus 60. That would be minus 140. It is minus 200. हमें minus plus नहीं देखना, हमें magnitude देखना है here. ठीक है? So इसका 140 आएगा. For potassium, it will be minus 80 minus minus 90. That is minus 80 plus 90 or 10. For chloride, it will be minus 80 minus minus 70. Minus 80 plus 70, that is minus 10. So maximum driving force किसका होगा? Which of the following ions the driving force will be the highest? हमारा आया है 200. Please don't see the minus sign. Okay, it is only for the cation or anion. The magnitude is 200 is the highest for calcium. So this is the correct answer. All right, this is the correct answer. Now moving to the next question. A 65-year-old diabetic. So, okay, moving to the microbiology questions. A 65-year-old diabetic patient with a non-healing foot ulcer shows greenish-bluish pus. Culture on McConkey's agar shows non-lactose fermenting oxidase-positive colonies producing fruity odor. Which of the following is not a resistance mechanism of this organism? Not a resistance mechanism. First of all, diabetic patient है, non-healing foot ulcer है, greenish blue pulse है, McConkey agar पे non-lactose fermenting oxidase positive colonies with a fruity odor. So what is the organism here? The organism, yes, it is Pseudomonas. This is the organism responsible. Now, the mechanism responsible for which of the following is not a resistance mechanism for this organism? Production of AMPC beta lactase. Again, yes, this is the mechanism responsible for beta lactamase resistance. Production of PVL. No, this is the mechanism responsible for your Staph aureus, not for Pseudomonas. Okay, this is responsible for Staph aureus resistance, and moreover, this is not a resistance mechanism. It is not a mechanism for antibiotic resistance. It's basically a factor responsible for tissue necrosis, tissue destruction. So this is the correct answer here. This mechanism is not responsible. Efflux pump, carbaminopase, yes, these are responsible for resistance of Pseudomonas, right? All right, moving to the next question. A 9-month-old infant presents with acute onset, profuse watery diarrhea, vomiting, and fever for 2 days. There are signs of moderate dehydration. Several infants in the same daycare center have similar cases. Stool examination show no blood or pus cells. Which of the following viruses is most likely causative agent? Okay, there is 9-month-old child, profuse watery diarrhea, vomiting 2 days, signs of moderate dehydration. And other children in the same daycare centers were affected. No blood or no pus. This rules out all your bacteriological causes, protozoal and bacteriological causes, because there is no blood or no pus. So viral infection hai. Now of these options, which is the viral infection responsible? Rotavirus. Yes, it is rotavirus. Why? Because it is the leading cause of severe dehydrating gastroenteritis in children less than 2 years of age, especially in centers like daycare centers, closed proximity. This is the most common cause of acute gastroenteritis, right? And severe gastroenteritis. It is not norovirus. Why? Because it can be seen in all the age group. First of all the age groups. And इसके लिए क्या proper history होती है? Proper history like in ships or in hospitals or schools. ठीक है? While this definitely can cause watery diarrhea, but उसका history और आपको different दी जाएगी, right? Adenovirus, yes, it can cause acute gastroenteritis in children, but it will have a longer incubation period and the diarrhea would be for a longer time. All right. Astrovirus again can cause watery diarrhea in children, but then there will not be moderate dehydration. Severe dehydration nahi hoga, it will be milder cases in astrovirus. So the most common cause of profuse watery diarrhea in infants in children less than 2 years is rotavirus. All right. Next question. Which of the following chemicals is used to sterilize heat-sensitive materials such as surgical instruments? Okay. Surgical instruments in hospital, we all know, we have worked in hospitals and we all know it is your ethylene oxide. It's a powerful gaseous alkylating agent. And what do we call? Cold sterilization. Okay, cold sterilization. Basically, all the hospital instruments, the bigger instruments and the smaller delicate instruments, ethylene oxide. Why is benzalkonium chloride not used? It's a mild to low disinfectant or an antiseptic rather than a strong chemical to sensitize hospital surgical instruments, right? Cresol or Lysol, it's a surface disinfectant for floors and topical disinfectant basically. Thimerosal, again, thimerosal is not used. It's a for previously it has been, it's a now obsolete, used for vaccine and all, but not used these days. So the correct answer is ethylene oxide. All right. Okay, moving on to the next question. This is a video, and if you see the video properly, what can you see? What can you see in the video? You can see a worm. I think this is a long worm which is moving inside. Moving inside what tissue? Can anybody tell me moving inside what tissue? It's a Yes, it's a subconjunctival tissue. It's an eye tissue. Why? You can see the eyelashes also and you can see the tortuous blood vessels also. Okay. So most probably it's the worm is lower, causing African eyes, also called African eye worm. Okay, lower, also called African eye worm. Now, they've asked you the organism shown in the video is associated with all of the following except it is transmitted by the bite of chrysops, deer fly. Yes, it is true. Peripheral blood smear for microvilli should be collected at night, 10 p.m. to 2 a.m. No, this is wrong. Why? Because it shows diurnal variation and the sample should be collected between 10 a.m. to 2 p.m. ठीक है, यहाँ पे उल्टा दिया हुआ है. It is in the daytime, 10 a.m. to 2 p.m. The nocturnal variation is seen in your Vaucheria branchofti or B. malai, not here, right? Lower में it is in the daytime. Infection can cause calabar swellings and ocular involvement. Yes, because of the microbial product. It can cause swelling. The drug of choice is diethyl carbamazine. This is again true. So the incorrect is it should be collected in the daytime rather than in the nighttime. All right, moving on to the next question. A 7-year-old unimmunized child is brought to the emergency department with fever, sore throat, and difficulty in swallowing for 2 days. On examination, a grayish-white membrane is seen over the tonsils and the pharynx that bleeds on removal. So what is it? It's a pseudomembrane which bleeds on removal, right? The child has cervical lymphadenopathy giving a bull neck appearance. Which of the following is the selective medium? Okay, selective medium used for isolation of this organism. What is the organism? It's Corynebacterium diphtheriae. Okay, Corynebacterium diphtheriae. And what is the selective medium used? Yes, the selective medium used is, what is for the first medium? Can anybody tell me what is the first medium? It's the red medium on which you see black colonies. Black colonies of Corynebacterium diphtheriae. This is the correct answer. And the medium is your potassium telluride blood agar. Okay. You will see black colony in lines. All right. So that is the, sorry. You will see bluish black colonies in line. All right. These are your Corynebacterium diphtheriae colonies seen on potassium telluride blood agar. So the correct answer is A. What is B? B is your TCBS agar. Okay. And it is used for your Vibrio cholera. You will see yellow colonies. Okay. Yellow colonies here. This is again your Loeffler's serum slope. Please note, you will see the Babe's Earnest granules of Corynebacterium diphtheriae here, but then this is a enrichment medium. This is your enrichment medium, not the selective medium, right? And now this, the D option is your LJ medium, and this is used for your Mycobacterium tuberculosis. Used for Mycobacterium tuberculosis, right? Lowenstein-Jensen medium, LG medium for Mycobacterium tuberculosis. The first option that is your potassium telluride potassium telluride blood agar is for Corynebacterium diphtheriae. All right. So this is the correct answer. Moving on to the next question. In the diagnostic workup of infectious diseases like meningitis, using a syndromic approach, which of the following molecular methods is most appropriate? Okay, diagnostic workup of infectious diseases like meningitis using a syndromic approach. Now, what is a syndromic approach? First of all, let's understand. A syndromic approach is basically involving a single test to diagnose or to assess, basically test various potential pathogens, the bacteria, viruses, and protozoa or fungi at the same time using a single sample. Could be a CSF in case of meningitis, to basically analyze the potential microbes for signs and symptoms, overlapping signs and symptoms of various syndrome. Meningitis, encephalitis, there could be various overlapping signs and symptoms. So if you have heard of the test called BioFire, where you use single sample, CSF, to analyze the potential pathogens, could be bacteria, could be virus, could be a fungus, could be a protozoa, right? And the most appropriate molecular method to test this syndromic approach is multiplex polymerase chain reaction. ठीक है, इसमें there are distinct pairs of primer pairs of several target DNA RNA sequences which are used at the same time to detect the various pathogens. If you see multiplex PCR, you see multiple primer pairs are used at one time only in syndromic panels, for syndromic approach, right? Meningitis, respiratory infection, GI panels, all the infections, syndromic approach is used using multiplex CR. Real-time PCR, you use fluorescent tracking during the amplification, and it is done for the quantitative, not the qualitative, quantitative viral loads for various hepatitis infections, HIV also. RT-PCR, we all know RNA is first converted to DNA before doing the PCR, and it is for the detection of RNA viruses. The nested PCR, two sets of primers are used in case where the infection or the DNA content is very low. Low copy of numbers, the targets are in low copy of numbers, so you use nested PCR. So here for syndromic approach, you will use multiplex PCR. All right. Let's move on to the next question. A 55-year-old patient had a tooth extraction 3 days back. He now presents with a mass in the submandibular region and is otherwise asymptomatic. There is no ulcer. On drainage, the discharge is foul smelling, lot of yellow granules. Gram stain shows gram positive filamentous rods. What is the most likely diagnosis? Once you see foul smelling, yellow granules in the question in the submandibular region, what is the answer? Very simple. It is your actinomycosis. All right. It is actinomycosis, right? Submandibular region. You also can they can also say lumpy jaw. Lumpy jaw is another word that they can use. Sulfur granules, yellow granules made up of your bacteria bound by the other tissue, surrounded by the other tissue elements, foul smelling, and the organism is actinomycosis, right? It's an anaerobic or microaerophilic bacterium. What will you see in chromoblastomycosis? The characteristic answer that they look for in chromoblastomycosis is your medullary bodies. But please note, medullary bodies will be on the potassium hydroxide preparation. Okay? Mucormycosis, you will see broad, non-septate, wide angle branched hyphae. All right. Histoplasmosis, you will see basically small yeast-like organisms, yeast cells within the macrophages. Yeast cells in the macrophages. That is, you will see in histoplasmosis. So the correct answer here is actinomycosis. All right. Okay, next question. A patient presents with a unilateral swelling of the left lower limb. Examination reveals palpable inguinal lymph node measuring approximately 1 to 2 centimeter. So there is lymph node enlargement. Fine needle aspiration cytology of the lymph node was done, and the following picture is seen here. What is the most likely underlying mechanism for this clinical presentation? Okay, even if they wouldn't have given you this picture, since it is in lymph node, तो सबसे most likely underlying clinical presentation का cause क्या होगा? Yes, it will be lymphatic obstruction. Now they've given you the picture. The picture is of Vaucheria bancrofti. Vaucheria bancrofti, basically what is it? It's a sheathed organism, the clear sheath microfilia, and the nuclei is not extending to the tip. The nuclei not extending to the tip. So this is your Vaucheria bancrofti, and it basically resides in the lymphatics, and resides in the lymphatics, it causes lymphatic obstruction, elephantiasis. Chronic obstruction can lead to elephantiasis. So आपका underlying mechanism होगा lymphatic obstruction, right? Okay, a child presents with diarrhea, dehydration, no blood in the stool. Again, no blood in the stool, no pathogenic organism, no bacterial organism. Stool examination reveals a spoke and wheel pattern. They've already given you spoke and wheel pattern. Spoke and wheel pattern है तो हमारा organism क्या होगा? Spoke and wheel pattern में organism, yes, the spoke and wheel characteristic of your rotavirus, right? Spoke and wheel pattern rotavirus में होता है, and cap जो spokes होते हैं, what are these spokes? These are basically your radiating, sorry, these are your radiating capsomeres. Okay, capsomeres, radiating capsomeres होते हैं, और central इनका एक hub होता है. These are your radiating capsomeres. All right. So the correct answer is rotavirus. Norwalk virus में क्या होता है? Norwalk virus में you will see cup-shaped indentations. E. coli, it's a gram-negative rod. Adenovirus क्या होगा? Adenovirus would be star-shaped. All right. Here it is rotavirus spoken wheel pattern, right? Next question. A 5-year-old child presents with localized swelling, pain, erythema, and induration at the site of routine vaccination administered 2 days ago. So localized swelling है, pain है, erythema है, induration है at the site of vaccination, which was given 2 days ago. The reaction developed approximately 24 hours after the injection. No history of prior similar reaction, and the child is otherwise healthy and up to date with all the immunization. Which is the most likely type of hypersensitivity? See, localized swelling, pain, erythema, induration है after 24 hours of injection. So it cannot be type 1 hypersensitivity. Type 1 hypersensitivity immediately होती है within 1 to 2 hours. Remember bee sting वाला question आता है हमेशा. ठीक है, it is type 1 hypersensitivity within 1 to 2 hours. So this is not possible. Type 2 hypersensitivity. What is type 2 hypersensitivity? It's basically immune complex mediated. This will also occur within 12 hours, around 4 to 12 hours में होगा. And इसके अंदर pre-existing antibodies होंगी. So again, this is incorrect answer. Type 3 is your antibody-mediated cytotoxicity, ADCC. Again, it will involve immunoglobulin and this will also present early, not after 24 hours. So the correct answer is type 4 sensitivity or delayed type hypersensitivity occurring after 24 hours, usually peaking between 24 to 48 hours, involving the T lymphocytes, T lymphocyte mediated hypersensitivity, where the T lymphocytes release the cytokines and they basically recruit the macrophages and all, and is responsible for your swelling, pain, erythema, induration. Most commonly, आपका PPD tuberculin skin test का बात हो रही है यहाँ पे. So it is a type of type 4 hypersensitivity. All right. So this is all for now. I hope I've been able to clear your doubts. In case you have any issues, you have any concerns with the answers, with the options, please do get back to us. Thank you and all the best for your exams. We'll meet you next week for the discussion of the next GT questions. Till the time, keep on solving MCQs, keep on revising your weak portions. All right, bye-bye, good night, thank you.